वो डब्बा थोड़ा ऊपर है।
We are live now.
Yes, a very warm evening to everyone. I welcome you all to this episode 12 of the Public Awareness Committee of Fogsi webinar. This webinar is with the North Zone. Since this series of webinars began in this series began in June, and June being the World Environment Day, so we thought to have topics related to environment. So for today's session, we have two talks. We have a couple of talks, one on the environmental factors affecting infertility and the other one on optimizing the treatment outcomes of infertility. And we have a very interesting panel on case-based approach to infertility. So I am Dr. Shatabdi. Me and Dr. Monica welcome you all. We will begin with the Ganesh Vandana. We'll take blessings of the Lord and then begin with our sessions. Abhishek.
Sound
आवाज नहीं है
आवाज नहीं है अभिषेक Okay, I think there was some issue with the sound. A very warm welcome to everyone, all of you again. Our chief guests for today are Dr. Rishikesh Pai sir and Padma Shri Dr. Usha Sharma ma'am. So I would like to welcome Dr. Usha Sharma ma'am. Dr. Usha Sharma ma'am is of course a Padma Shri holder. She is the ex-Director General and Medical Education of Uttar Pradesh. She is a principal cum professor of the Gynecology and Obstetrics at LLRM Medical College, Meerut. She is the lifetime chief patron of the UP chapter of the Obs-Gynae Society. She has various awards, including the Padma Shri to her credit. We welcome you, Dr. Usha Sharma, ma'am. Kindly give your comments and give your blessings so we can go on.
Thank you very much, Shatabdi, for saying such nice words for me. Dr. Rishikesh Pai, he has not joined yet, and we all know how dynamic, competent, and hardworking president he is. And then Sarveshwari, guest of honor, she is so close, she's so affectionate, but unfortunately she has not been able to join. And Sujata Sharma, she is also a guest of honor. I don't see her also here. Maybe there must be some problem with her. And then, of course, coordinator of today's program, Dr. Monica, she will join us afterwards. And then Shatabdi, she is very much here and she has started the program so well. And then conveners, we know our dear, loving Dr. Anita Sabarwal and Dr. Vidhu. And we have two learned speakers today. Dr. Sadhana Gupta and Kanchan both are very knowledgeable, very competent, and we will be listening their talk today regarding infertility. And then we have a panel discussion. All of us know that it is a very important because it is case-based discussion, which is very fruitful and informative. And moderators of that panel are two very, very dear persons, and I can say they are so dedicated and hardworking persons, Rajul Tyagi and my dear Preeti Jindal. Preeti is just like my daughter because she is daughter of my very good friend, late Dr. Urmila Agrawal. जब भी मैं प्रीति को देखती हूँ तो मुझे उसमें उर्मिला नजर आती है, and she will be moderating the panel today. And then we have expert for the panel, Dr. Ekika Singh and Dr. Poonam Lamba. Both of them are so known to our Foxians that I don't need to tell more things about her. And then worthy panelists, of course, all of them are very, very knowledgeable person. And today, it's a great pleasure for me to be with you all on the occasion of this webinar on infertility. All of us know that India is a very populous country in the world. And we also know that it has surpassed now China also, unfortunately. And then we know that in spite of such a populous country, we have about 15 to 16% of eligible couples who are seeking treatment for infertility. And actually speaking, the reported number is about 30 million of the infertile couples. But if you go to the factual, I think it will not be less than 50 million. And that is why we always say that it is very important. जहां एक तरफ पॉपुलेशन एक्सप्लोजन रोकने की तैयारी है, वहीं इस इनफर्टिलिटी के ट्रीटमेंट को भी हम लोगों को जरा जोर शोर से करना चाहिए, क्योंकि पॉपुलेशन एक्सप्लोजन से ठीक है फिजिकल प्रॉब्लम्स होती हैं, पर मेंटल ट्रॉमा और स्टिग्मा और द प्रॉब्लम्स फॉर वुमेन आर सो मेनी that it is really very, very sad if a couple is infertile. And that is why it is always a responsibility of all of us to create awareness regarding the infertility treatment and give them the best by which we can really help them in their day-to-day life. Now, we all know that menopause in our country is about 5 to 6 years earlier than the Western world. The male sperm count as well as the AMH in ladies also declines with the age much earlier in our country. And these things are actually very much important in our day-to-day life and for our fertile status. And now we all know that the assisted reproductive technology is growing leaps and bounds these days. In spite of the fact that it is growing so much, still there is a need for a lot to be done, because we know that the outcome or the results of this fertility management differ from center to center and city to city. And really, I would like to congratulate the whole team today who have organized this webinar, in which they have really involved a IVF expert, Dr. Rishikesh Pai, who is so well versed with all the problems of ART and AI and whatnot, and along with the senior and junior faculty of North Zone, that I'm sure that today's webinar will be a step forward for standardization of the fertility outcomes across the country. I'm sure that the deliberations today will go a long way in updating the knowledge regarding infertility of each one of us. And I wish this program a great success. And thank you very much, Monica, Shatabdi, and the whole organizing team for making me a part of such a prestigious and informative webinar. Thank you very much. And I wish you all a very healthy, happy, and bright future. Thank you.
अरे हमारा नाम भी तो ले लेती हैं।
यार सॉरी अरे भैया, ये वर्दी चेयरपर्सन कैसे रह गए? ये मंजू तो मेरी जान है और मेरी शान है, and I can say that she is the strongest pillar of UPCOG. जाने कैसे चेयरपर्सन के नाम रह गए भैया? मंजू शुक्ला मुझे याद है, मंजू शुक्ला, ज्योति, अनीता सबरवाल as well as विदु. I don't know how I missed it. मंजू, तेरे बगैर तो मेरी कोई चीज पूरी नहीं होती है और तेरे बिना तो मैं अधूरी. थैंक यू सो मच मंजू, याद दिलाने को कि मैं पैनलिस्ट भी बोल दिया, सब बोल दिया, ये चेयरपर्सन कैसे रह गए?
नहीं ना, चेयरपर्सन मंजू तो बस
अरे यार, मैंने कह तो दिया, तू तो मेरी शान है, मान है, मेरी जान है.
Thank you so much. Thank you, ma'am. Your words mean a lot to us. Thank you for those words of motivation. We have always been and will continue to remain inspired by you. Our guest of honor, we will move on with the program. We'll take Dr.
Shatabdi. Shatabdi, I have joined this.
Shadaveshwari aa gayi.
Ma'am,
Yes.
thank you so much for the blessings. Please join all our programs. We are very, very inspired by your thoughts, ma'am. Usha Sharma, ma'am, thank you.
Oh, Monica, I always appreciate your promptness and your capability. कोई भूल नहीं सकता कि वेबिनार कब है और
हाँ।
कितने बजे है. याद
हाँ,
दिला
yes,
दिला
ma'am.
के बिल्कुल एकदम अपना काम पूरा
अभी
करती है.
अभी भी 15
प्रणाम
मिनट पहले.
प्रणाम डॉक्टर मैडम उषा शर्मा, प्रणाम मंजू शुक्ला मैडम,
प्रणाम साधना,
प्रणाम
प्रणाम.
प्रणाम प्रणाम.
मदुरई
Thank
में
you,
हूँ
ma'am.
और मीनाक्षी टेम्पल की सबको ग्रीटिंग्स और शुभकामनाएं दे रही हूँ.
चलो
Thank you.
तो सभी
Thank you, ma'am.
टीचर्स को प्रणाम और कंचन, अनीता, प्रीति एंड loving regards to all of you.
Thank you.
I take privilege in introduction of our guest of honor, Dr. Sarveshwari Nautiyal, ma'am. She has sent her greetings from Heathrow because she is in the flight right now. Madam has been awarded the fellowship of the ICOG in 22. She is the founder and managing director of Kishori Foundation, a pan-India NGO. She is also the former director of Medical and Health Services, the government of Uttar Pradesh, the former superintendent-in-chief of the District Women's Hospital, Allahabad. She has organized a clinical research screening program for thyroid disorders and antenatal cases. She is the ex-director of senior consultant and colposcopy. We welcome ma'am, and I request Abhishek to please play her message along with the CV also.
First of all, I want to thank the organizing committee, Public Awareness Committee, Fogsi with North Zone, for giving me this opportunity to be with you all. My pranam to my teacher and mentor, Padma Shri Dr. Usha Sharma, and regards to our President Fogsi, Dr. Pai, a great infertility specialist known internationally. I wish I would have been there to meet you all, but as I am on the way to US, so sending my best wishes for a successful webinar. I know infertility is a well-known condition which is a real difficult problem for the patient and doctors too. I'm sure everyone will be benefited by this webinar. It will be a real academic feast to all of us. A special thanks to Priyankur and all my best wishes to Dr. Sadhana for coming elections. Once again, I can say my best wishes to Kanchan and Monica. You are the one who kept me in touch with all the things. Once again, thanks to all and all the best for the successful webinar. Thank you.
Thank you so much, ma'am. Your blessings mean a lot to us. We move now forward for the next guest of honor, Dr. Sujata Sharma, ma'am. She's a senior consultant at Apollo Specialty Hospitals. She's the immediate past president of Amritsar OBGY Society. She has been the past HOD in the Government Medical College, Amritsar, the past director of Medical Education and Research Publication, the past principal of Government Medical College, the past medical superintendent of Guru Nanak Dev Hospital. Madam has been traveling since today morning due to an emergency health issue. So she also has sent her greetings for this webinar. Can we have the message, please, Abhishek?
Good evening, everyone. First of all, my thanks to the organizers for inviting me to this webinar as a guest of honor. I personally wanted to be here, but due to some travel emergency, I had to leave. So today's topic is very, very relevant in today's scenario because wherever we go around the globe, whether in India, infertility is the most talked about topic. So whenever I travel around, I always find so many people suffering from infertility, and that's because I'm a gynecologist and maybe I'm just listening to this aspect of gynecology and not any other conditions. Of course, NCDs also are becoming too common. But our topic for today is infertility and its management and its etiology. As we know, it is becoming a big global problem with the prevalent incidence as reported in different literatures ranging from 8 to 12%. The male and the female infertility. Now, both are at par as far as incidence goes, and various conditions which are leading to infertility in females like PCOS and many other conditions, endometriosis or tubal factor infertility or in unexplained infertility. So all these factors are also becoming very popular, very common because of genetic as well as epigenetic conditions, the environmental conditions. And that's why the increase in the incidence, and also the incidence appears to be increased because of the greater awareness amongst the masses towards the availability of treatment for infertility, and more people are coming forward with their problems. Now, male infertility is also very common, becoming more common than the female infertility, and will, of course, surpass female infertility one day as it is going on. And the basic factor is the epigenetic factors and the environmental factors which are causing it. There's a huge research which is going on in both these fields at a very, very fast pace, so fast that sometimes it becomes difficult to keep pace with the research which is going on. So, be it female infertility or be it male infertility, with so many the intricacies of the ovum and the this and the sperm interaction, as it is becoming more and more clear. So we are getting into more and more research. So many advanced sperm function tests, be it MC, be it PIXI, be it sperm fragmentation tests by fringes, to microfluidics, which is a recent one and has the most promising future. So all these tests, the disadvantage of these tests is that they are function specific. As of now, there is no one test available which will test all the functions of the spermatozoa which are required for that very, very intricate interaction with the ovum. And with the research going on, and also government of India now trying to establish National Research Foundation, I hope and I wish our Gen Next will get into more and more research, and one day we also get to see people who will have their name in the world literature like Edward and Steptoe have. So, my good luck to the speakers, to the moderators, and to the panelists for a very, very interactive session. And I hope the audience will enjoy it to their best. Thank you.
Thank you so much, ma'am. With this, we declare the inaugural session as over, and we now move forward for the first scientific session with the topic of environmental factors affecting male and female infertility, with the speaker none other than Dr. Sadhana Gupta, ma'am. I take privilege in introducing the chairpersons for this session, Dr. Manju Shukla, ma'am. She is the retired professor of KGMU Lucknow. She has been the president of UPCOG, president of the Lucknow OBGY Society, the chief editor journal of UPCOG. She has been the president of Association of Private Gynecologists Lucknow. She is a master trainer in contraceptive technologies by Japaigo, a master trainer in emergency obstetrics, master trainer in maternal health, and assurance international assessor for Lakshya Kayakalp in the National Rural Health Mission. We welcome you, ma'am. Our next chairperson for today's session is Dr. Jyoti Bindal, madam. She is the Vice Chancellor of the Sri Aurobindo University, Indore. Her major achievements include the J.G. Ojoli Oration 2021 by the National Academy of Medical Sciences, the Fogsi Shiromani Award in the year 2020. She has been the President Association of Madhya Pradesh OBGY Societies. She has been the strategic advisor and member of the executive committee BTA UK, member of the COVID Technical Advisory Committee, the State PCP NDT Committee, and the District Gwalior PCP NDT Committee. She has been the ex-dean and the CEO of the MGM Medical College, the director of Gwalior Mansik Arogya Shala, dean and CEO of Government Medical College Shivpuri. She is also the member of the core committee of National Human Rights Commission. We welcome you, ma'am. I request Manju ma'am to please introduce Sadhna Gupta madam and Jyoti ma'am to introduce a topic in short, ma'am.
It is my pleasure to introduce Sadhna, the presidential candidate for this coming election. And she is co-chair SAFOG NCD committee, Fogsi representative in SAFOG 2018 to 221, Vice President Fogsi 2016, ICOG Governing Council member 2015 to 2021, the Best Governing Council Award 2021, corresponding national editor and peer reviewer of Journal of OBGY and Journal of SAFOG, Fogsi past chairperson, Fogsi Safe Motherhood Committee with Fogsi Dr. Mehru Hansotia Award for the best committee Newborn Care Millennium Development Goal. 3 times Corion Award winner for best scientific research paper, 4 times best AICOG research paper, sole author of book Caesarean Delivery, Vaginal Delivery, a comprehensive textbook of OBGY, JP Publications, editor 7 Safe Motherhood Bulletins, ICOG, Campus and Foxy Focus and Book. ये तो साधना बिल्कुल राइटर हो गई, ये बहुत सारी चीजें इसने लिख दी हैं, बहुत पढ़ते पढ़ते तो पूरा टाइम हो जाएगा. Many awards to her credits, Award of Chancellor and Dr. Naval Kishore Gold Medal for Best MBBS and Postgraduate Student, key organizer of national and international conferences, Adolescent Congress 2002, ICOG Conference on Maternal Mortality 2007. She delivered keynote addresses and orations in national and international forums, namely by June Thapa Oration at Nepal, honored at the National and International Forum for exemplary work done to reduce maternal mortality, commonly community service and women. Foxy Duru Shah Award for Distinguished Community Service, awarded Foxy Paper Achiever Award 2023, Pride of Foxy Award 2019, Foxy Star Award 2016, recipient of NA Shalza Pandit Award for Women Empowerment 2021, Economic Times Award for Service in COVID Times 2021, Director and Senior Consultant OBGY Jeevan Jyoti Hospital and Medical Research Center Gorakhpur. And वैसे तो साधना is my good friend, I will say. अब वो समझे ना समझे, साधना नहीं ये ऐड करना पड़ता है.
Thank you ma'am for all the CV. और आपको तो आप दो दोस्त नहीं, आप हमारी टीचर हैं, टीचर ऑफ टीचर्स हैं, और यूं आप सबकी मित्र हैं, वो है. So thank you ma'am, and my sincere regards to Dr. Usha Sharma ma'am, Dr. Sarveshwari, Dr. Sujata is not here. So that I always say that Dr. Naval Kishore postgraduate is gold medal for best student, then Dr. Usha Sharma was our external examiner.
Yes.
So I hope that I did justice to madam what you have like seen me as a student. And my sincere regards to Dr. Jyoti Bindal, a teacher of teachers, and had a very, very long association. And incidentally, my elder son has done the graduation from GR Medical College, Gwalior. And at that time, Madam was there, and a wonderful Yuva Foxy over there. And Dr. Manju Shukla, she is friend of friends. And always she teases us with the thing, and it is her bit of humor for which she is loved everywhere. Congratulations, Dr. Priyankur, Public Awareness Committee, and Dr. Monica for keeping this environment in the issue, because actually this is the thing that we as a infant, as a OB-GYN or as a ART specialist, actually we somehow forget that what is happening around our world and around us. I will be.
Sadhna, can I interrupt you and as a chairperson?
Yes, madam. Yes,
can
madam.
I interrupt you for a minute?
Yes, madam. Pleasure.
Although Dr. Manju Shukla has given such a glowing introduction of yours, but I cannot refrain myself from speaking a little about Sadhana. Having said that, as she said, as Dr. Manju Shukla already said that, Sadhana comes across always as a friend. But in my life, I feel her, she has a very special place. And that's why the minute I heard from Priyankur and Monica that I was to chair a session where Sadhana is going to be speaker, I said 100%. Why not? And then I had an interaction. I told Sadhana, I always remember you as PPH lady. I just can't think of you beyond that. So what are you going to speak on infertility issues, And I still remember the first exposure I had of her was many, many years back. And at that time, there was nobody who could even think of those drills, which she said, skill workshops. And I remember during COVID times, she continued with those skill workshops and drills, which I don't think anybody has done in this atmosphere of COVID, the way Sadhana went on. And of course, she is the presidential candidate, but besides being any post holder in Fogsi, I think she's a very, very genuine human being. And that is what is probably her best asset. And Sadhana, I have to tell you is this, that though you do have competitors in your presidential campaign, even your competitors, a couple of days back, I was speaking to one of them and they said, ma'am, honestly, she's a very, very nice person. And this coming from your opponent is a big, big deal. So Sadhana, really, I'm so happy that to be with sharing the same platform as you. Wish you all the best. And although Monica did ask me to speak a little about the subject, but I think I'm going to let Sadhana go on with her deliberation of the subject.
Thank you, ma'am. Ma'am, your words were really like it is something very special and precious for me. And it is all because we have been guided by the teachers like you, Dr. Usha Sharma, Dr. Manju Shukla. It is all what we have learned from you. And really, the final thing is that if any opponent says to you, then I think that we have lived our life well. So with this, with a again, sincere regards and gratitude for all precious and the loving words. I will be taking environment and infertility and how it is so important in today's chances. So just a minute, yes. So a gratitude for always what Madam says, it is a glimpse of all physical and the workshops, what Madam says, the PPH, and at that time we could think of drills and all the TOTs which we happened in the different state. So it was a journey worthwhile, and we get on like being with great and the dedicated people. And I bring at the moment I am at Madurai, the city of temple, and bring greeting. My workplace is Gorakhpur, and where the Buddha sleeps for like his eternal heavenly sleep. And we must be peaceful in ourselves, and only then we make the world peaceful. And the Indian philosophy and way of life is that we treat every minuscule. We worship trees, we worship birds, we worship animals. And this is the way actually we have to carry on if we really wish to have a very peaceful and a healthy life. We had a great tragedies in 19th and the 20th century, the atom bomb fall on Hiroshima, Nagasaki, Chernobyl accident, and then our own Bhopal gas tragedy. And Dr. Jyoti Bindal belonged to that state. We remember I was first year MBBS, first year MS student at that time. And we know that how these things have gone generation to generation, infertility, congenitally abnormal baby. And what we are having, it is not the day-to-day accident. Actually, as a human being, we are exposed daily to so many toxin and chemical in day-to-day life. And how it is affecting infertility, we will be just looking into it. WHO says it is around 10 to 12% of the couples are having difficulty in conception. And important thing is that industrialized nation have the more chances, more incidence of infertility. Maybe it is a primary or secondary. And it is like most of the people had to have the waiting time of more than 1 year to become pregnant in today's time. So question is that, is human race becoming gradually more subfertile? And let's see, yes, human fertility is declining worldwide. So it may be due to choice. People are opting for contraception. People are delaying childbearing for so many things. But important thing is that it is a real issue. That's why we are having more and more technology, like we are having ICSI, we are having IMSI, and we are becoming more and more technical thing that we bring something like we bring somehow life to the new one by doing this fertilization. But important thing is that we are actually treating the something which is, we are not having that integral medicine that is really treating that they are potentially they are more fertile. So what is this thing, environmental toxin? So as a OB-GYN, we know, be it a infertility, be it a implantation failure, be it a early pregnancy loss, it is a abnormal gametes which we are. And whenever, like I am in IVF since 15 years, and what we want, our embryologist says, we says, in our all teachers say, what we want, a good gamete. So to the patient, we also say, it is your body, it is your gamete, and that will give the result. It is not only the technology, actually what we have. And this environmental toxin, chemical pollutant in workplace, which are there in soil, air, water, food we are having, it is having the detrimental effect on the human gametes. Maybe it is a female or it is a male. So we are all the sum up of genetics and environment, and it is in our genes. We were built to wander. So be it like a election campaign or the workshops and the teaching and the training, but actually it is in our genes that we were built to wander. And when we had an increasing population, what Madam Usha Sharma says, that who has done a tremendous work on the population stabilization. When we have the increasing population, we needed more food, more clothes, more jobs. And then the technology came to save this thing, that have the more food, but somehow we are dropping thousands of chemical in our environment. And again, there is a cycle that the environment which is causing decreased fertility. So it is something which is a balance in the nature. And what we will say, we always like remember the Gandhi's word, that this earth can actually provide everybody's need, but not everyone greed. So this is something Western world always take a lot of carbon imprint, and we had been, the Indian people have been very simple in living, but somehow the things are changing. So what is the visible environmental hazard? You go at any road, you go, just go beyond your posh area of the city, and you will see heaped garbage, blocked drainage. That is a uncontrolled city development, and invisible, which we are not knowing, that is organic solvent, heavy metals, pesticide, and endocrine disrupting channel, which is causing a lot of disease, but also infertility also. How these environmental toxins cause infertility? They can affect female as well as male. They can be endocrine disruptor, and they can have the impaired fetal viability also. So when we are having always a discussion on the recurrent pregnancy loss and implantation failure, this is the thing that the environmental toxin should be in our thought process, because we know that the metal, chemical in air, water, food health product and the beauty aids are damaging fertility in many ways, and toxin, they are causing decreasingly sperm count and the function, and women are having more and more anovulation. We all know that the more and more people we are seeing that they are not having regular cycles, impaired implantation and RPL. So environmental toxins are implicated in pathogenesis of many chronic disease, and we are exposed to around 80,000 environmental chemical, which we can count a little bit, and it is an exotic model which actually disturb the cellular function and chronic disease. And only the nanogram level of these toxic environmental chemical may disrupt the cellular function and lead to chronic disease. So endocrine disruptor are the chemicals who have the deleterious effect on the individual because they are interrupting the endocrine function. How they cause subfertility? They can be epigenetics, oxidative stress, transcription factor, and the endocrine disruptant, which cause the affect the signaling pathway. So in many ways, when we inhale, when we eat, when we imbibe, when we absorb through skin these chemicals, they can like affect the fertility and they can cause other disease also by all these ways. What are the pollutant? We know we will can count few, and we cannot understand every pollutant because it is a DDT, DDE, ketone, dioxin, PCBs, breakdown product of detergent, which can mimic hormone estrogen and affect the reproductive physiology. So many chemicals are the mimicking the hormone estrogen, and especially that all mineral water bottles, they are supposed to be like a compound which can mimic the estrogen and causing a lot of endocrine disruption in our body. These compounds are disseminated through air pollution, then they deposit in soil, water, and enter into the food chain. And female population who is exposed to chemical and pollutant, they will take longer time to conceive. This is an Earth study in 2018, which is a large-scale prospective cohort study over 20 years, which examine impact of environment, diet, and lifestyle on human reproduction. It studied 131 food, beverage, as well as supplement, cosmetic, and daily personal use item. They analyzed urinary biomarker of more than 40 chemicals, and out of this research, around 130 publications were made. And it is one of the findings that the higher urinary concentration of some phthalates were associated with decreased oocyte lead, lower clinical pregnancy, and live birth rate even with assisted reproduction. So actually what I was to say, this is very important statement that as a RT specialist, when we are going more and more technical and more costly, actually we are not really looking into increasing the fertility and the fecundity of couple. And as a OB-GYN, this should be the way ahead, the way as a doctor we should think for it. So this is a long list of the chemicals of radiant heat, heavy metals, cigarette smoke, alcohol, ethylene oxide, which can cause infertility, subfertility, miscarriage, and the pregnancy loss, as well as the adverse obstetrical outcome into the patient. And this is the BPA, what we know out of many things, only few we could have studied. That is BPA, phthalate, air pollution, dioxin, pesticide, chemicals, triclosan, and the paraben, which can cause the decreased central follicle, preterm birth, PCOS, and the adverse obstetrical outcome, as well as the endometriosis and uterine fibroid are also related to the environmental pollutant. And it can be a reasonable thought because somehow it is not so that we are diagnosing, actually we are having a sudden surge of the woman with PCOS and endometriosis and fibroid in a great one will accept. We were not seeing it around 10 to 15 years ago. So this is a systemic review of fertility, sterility on outdoor air pollution and human infertility, and the particulate matter of the certain size, nitrogen dioxide, sulfur dioxide, carbon monoxide, they all can cause the subfertility. So how carbon monoxide work? It unite with hemoglobin in RBC, causing carboxyhemoglobin, which is more many chronic disease, and that's why the sulfur dioxide which cause the decrease in DNA synthesis. This is a systemic review in 2014 that high concentration of NO2 and particulate matter with diameter of this 2.5 and 10 microgram. Micro has the detrimental effect on the live birth rate and increased miscarriage rate. Many companies, whenever you put the lab, every year they will come with the advanced air filter. We always say that don't make the ART lab at the basement, don't make the ART lab when there is some construction goes on. And how the air filter, like we are having so much of buffer area, but despite that the environmental pollution affect very marked way our ART results as well. So what we say that it also affect the IVF much likely to succeed, and these are BPA, organophosphorus, organochlorine compound. So as a OB-GYN, we are not very used to it, but the few things which we always listen and read in the newspaper, and we know, yes, these are and a lot of things about the organic farming, which we actually don't know how really what is the a truth when we have a sale the organic food, but actually it is, I think it is not possible for a larger number of the population. Chlorination of drinking water came as a boon to prevent the diarrheal disease and the infection associated with orophycal route, but the chlorination of the water causes 4-THM, that is bromodigromethane, chlorobromomethane, bromoform, and the drinking chlorinated water is associated with increased risk of stillbirth as well as with IUGR and smaller head circumference. And why this is so important, that we are always, we are doing the academic session, a lot of discussion of the unexplained stillbirth IUGR, and can the environment be cause of these things? We have to look into it very carefully. Endocrine disruptor, what we say, PCOS is a silent epidemic affecting around 15% to 20% of the population, and the endocrine disruptor has been considered a very important emerging concept, that they are causing the polycystic ovarian syndrome as well as all PCOS related adverse disruption, abnormal steroidogenesis, abnormal oocyte development, follicular growth, and the diabetes type 2, atherosclerosis, and the fertility problem. So extremely Monica,
Yes, ma'am, you're audible.
Yes, ma'am, you're audible.
Yes,
yes.
very clear.
So environmental exposure to industrial xenoestrogen, including BPA, what we say, and the plastic have to be shown. They are present in utero, cord blood, breast milk, children, and adult. And this has been association between endocrine and the PCOS. And we really need studies. But one of the very important clinical point with this is that when we counsel about weight reduction, we have to be very focused on the quality of the diet and avoidance of our hydrogenated oil, packaged food, preservative, and sweetener, which is one of the very important things. Pesticide and herbicide, they also reduce the decrease in fertility and all the things, and the IVF women with highest level of the PCB were the more unlikely to achieve pregnancy. And this is such an important statement. The women undergoing IVF, those with have the top body load of BPA were 201% more likely to have implantation failure. So that is the thing. And when we are struggling, getting on adjuvant, getting on this thing and that thing, we have to look at what is happening around our women and their families. So chemicals, beside occupational exposure, women working into the industry, women working into the farm, there can be non-occupational exposure, like women drinking groundwater with the tetrachloroethylene contamination suffer over a double risk of spontaneous abortion as well as increased risk of breast cancer. Heavy metals, again, very important, and the few metals are very important, that is a cadmium and the thallium, and they have the significantly higher blood level of the mercury than in fertile control. The people who eat more seafood, they can be the higher mercury level than other general population. So heavy metals is something, and we have to be more careful, because in many Ayurvedic drugs, they are using a lot of heavy metal, and we have gone through few papers that the heavy metal load is like concentration is high in the semen of the infertile male partner. Smoking, we know a lot of obstetrical complication, and what we say, when Ireland banned smoking in workplace, the preterm birth dropped by 25%. So around 20 years ago, the people used to smoke everywhere in restaurant. Now we are lucky that we have all the non-smoking thing, and the smoker place is different, and actually it affects the public health problem, and it reduces so many respiratory disease as well as the fertility indirectly. Passive smoking, we know, like any person who is smoking beside us, and it is not only smoking, it is the one living who are living near the busy road. So the people who are living close to highways, close to railway track, they can have a lot of positive passive smoking, and the high level of the sulfur dioxide, carbon monoxide, and the N2O, and that can cause alteration of sex hormonal level and the infertility as well. This is the future. This is the study which has been registered in 2022, and it is focusing on the process of identification of environmental factor that might lead to high infertility rate among women, and will be following a specific rule and restriction which can help in managing the growth in fertility process and secure population growth. So this will be a very important paper, and we will be awaiting its result, that how environment is important for the fertility. So this is the population, more population, we had to go to technology, but somehow the human wisdom is really lost. And we say that actually what we know, when we are having so much of parties, so much of outgoing, and like out eating, and so much of the like air conditioner, that we are not able to like go through even like few minutes without AC, and without AC. Actually, this is time that we as a human being have to say that what amount of carbon imprint we are actually leaving behind our every act. So it is something. Two researches, because we say that we want evidence, but it is very, very difficult to have the research for the environmental toxin, because we have to produce animal studies, then the same one toxic, but the humans are exposed to many environmental toxin and chemical, and it is very, very difficult. So very important thing is that as a human, as a doctor, we have to be very strong voice in primary prevention in combating environmental hazard. Now coming to male infertility and environment, actually the male genitalia is outside the body, and the environment can have more detrimental effect on the male organs and the male fertility. So we now know that the male is responsible for around 50%. It is a very, very high incidence, and the increasing concern of decreasing count is all over. It is a global decrease in sperm quantity and the quality. So the challenging environmental and the lifestyle exposure, and I wish to draw everybody's attention that it is not exposure of the man only into the adult life. Right from the in utero gestation to advanced adult age, the male infertility can be caused by chemical toxin, mothers smoking, mothers taking alcohol, and mother having the high weight and the bad diet and exercise. So in utero, in the gestation period, if the mother is exposed to fertilizer, pesticide, herbicide, plastic, and then in the younger age, when the boys go towards smoking, alcohol, all college thing, all young thing, and then in adult age, the scrotal heat stress, cell phone radiation, psychological stress, all things cause a sharp decline and the gradual increasing decline in the male fertility. So as a mother, what we say, our Indian philosophy, were like somehow we say it is a retrograde thing. But actually the Indian philosophy was so considerate that what mother think, what mother eat, what mother drink, and how they should be protected from the outside stress. Somehow we are really losing the track, and we have to be very, very like back to our Indian ways, back to our Indian diet. Actually, they had the science because that is merging with the scientific observation. So the prepubertal in utero gestation, what we say, the smoking of mother during pregnancy, yes, adverse obstacle outcome. Beside that, it can reduce the Sertoli cell number. Likewise, maternal obesity, harmful hermicide, all can cause the future. The male child is born and they can have the reduced reproductive potential. The use of diaper. Now, this is very, very important that the certain type of diaper, and you can say the most of the diaper can cause the testicular heat stress in infancy, and it may be partially responsible for declining sperm count. So as a doctor, we have to, and as a Foxy presidential candidate, actually what I have done, that is a positive, promotive, protective Foxy, and environment and nutrition is the thing which we have to be very, very loud, and we owe this responsibility to the people we treat and the citizen of our country. So mature human being, what we say, the it is male, the from adolescent to the old age, they are always having spermatogenesis, but we actually, it is what we say, it is difficult to have the studies because we are relying only on the animal studies. Geographical variation, so this is again what studies say. The rural people will have the different fertility, people in the occupation, what occupation they are having, bank, sitting occupation, IT sector, and they have got definite relation with their occupation. All these things, what are all chemicals or air inhalation, skin exposure, all things which will affecting female infertility will affect male in a much better, much more way. So that is the, with over 7 billion population, the food production has been engineered. So we had the Harit Kranti in our country, when our country, like when Indira Gandhi 19, like it was 80s, when we don't have that wheat and we go for the Harit Kranti, that came the use of fertilizer, pesticide. Now we are one of the largest grain producer, but it is the cost of many, many issues and the use of fertilizer and pesticide and the food preservation is causing toxin to enter into our bloodstream and causing a lot of oxidative stress as well as the fertility issue. This is the carbenzime, is a systemic broad spectrum fungicidal which is used to spray on fruits and leather, and it has been found to have a detrimental effect on male reproduction, including testicular size and reduced seminiferous tubule. As a practitioner, it is that something practiced, and I will say most of this, whenever we are dealing with the infertile or the patient with couple with the pregnancy loss, always I be meticulous that what profession they are having and what is their daily routine. So this is something very, very important. Many chemicals and toxin we have told what is affecting the female infertility, that is also causing the male endocrine disruptor. And important thing that the male is suffering more because many chemicals are having estrogenic properties, and in addition it is increasing the ROS. So we are always prescribing months and years of the antioxidant, but there is something which is feeding by the environmental toxin, which is in our food, which is in our preservative, which is in our air, traffic pollution, and the spermatozoa, which are very, very rapidly dividing throughout the life. They are very susceptible to rapid oxygen species and lipid peroxidation because they have a large amount of polyunsaturated fatty acid found in their membrane. So the male spermatogenesis is something, a unique phenomena in the nature, because it goes up to the last stage of the life, which is start right from a very early age. And the chemical toxin which generate rapid oxygen species in spermatozoa are very, very significant. So man in highest quartile of the higher pesticide residue fruits and vegetable, which is having more than 1.5 serving day, had a significantly lower sperm count and the significantly lower abnormal sperm as compared to men who have the less exposure to these food preservative. Plastic is the material of modern time. All packing, everything is in a plastic. We are in a plastic world actually. any chemical which make the plastic clear, heat resistant, unbreakable plan. So all our micro oven, all our, like the fashionable, what is the utensil in which the food is being made, they have all many toxin, especially bisphenol, which is found in the polycarbonate plastic, and all disposable plastic warming lid of the food container, they enter into our body. The second very common found chemical is a nonyl phenol, which is synthetic plastic additive, had estrogenic property and can accumulate in tissue due to its lipophilic nature. Where it is found? It is not in the chemical or the factory. It is found in detergent, paints, personal care product, food processing, packaging industry. And vast prevalence of these chemicals in our daily life is there. Heavy metal toxicity, so the lead, cadmium, mercury are the three metal of the concern, and they, when they are exposed to their in their occupation, they can have the toxic effect. It's smoking, alcohol and drugs, and the use of anabolic steroid. Everything is on the rise. We have a little bit less cigarette smoking, but we have all alternative ways of tobacco, and somehow it is matter of concern when our society had some stigma, social stigma about use of alcohol. It was good actually. Now we are losing that stigma very very sharply, and it is always right from the very early age. The alcohol consumption is way of life, and but it can cause a lot of issue: impotence, testicular atrophy, reduced gonadotropin secretion, and the body image. Everybody want to be Salman Khan or something, or six pack, and the gym people are using anabolic steroid, which can cause really hypogonadism and the agiospermia. Diet and obesity, I will not go into detail. It is itself a big topic, but important thing is change in our diet. Packaged food, highly refined carbohydrate rich food, simultaneously less fruit and vegetable, and especially then the containing like and the lack of oxidants, antioxidant, essential nutrient, and the obesity in many ways. First of all, fat produces estrogen. Secondly, it causes the heat in the scrotal region, and that cause also the poor spermatogenesis. So obesity itself is an independent issue which relate to the infertility and in the male, and this is the endocrine and the exocrine function, and the lowering BMI in obese man can be solution to some infertility issue. Scrotal heat stress, because we say welders, patient who are in the cooking, baking industry, in the glass industry, they are exposed to high degree temperature. But the other thing is the tight jeans and the tight undergarments, lack of exercise. So these are the things which as a clinician we have to like inquire about it. And this is very important statement, that the moderate exercise have been found to allow air circulation and cooling scrotum. But if there is a extreme exercise, it may raise temperature. Like moderate and walking and biking may be beneficial, but competitive biking can generate heat stress. So nature have never defined the humans or the living being to be competitive. It is we don't see in the nature's other species, but it is something that when we want to have more and more, so we are eating here and there, and we are wrong eating, and we are going to gym. So it is something that we have to a little bit cool down and go to our natural ways. Cell phone radiation, especially near the pants, they cause a lot of ROS and a lot of rapid oxygen species. And the important thing is that the cell phones is actually 24 hours, they are sending the electromagnetic radiation, but we are actually not using is 24 hours. So unnecessarily the human beings are exposed to all these cell phone radiation, and somehow we must be very scrutinized in using the cell phone for our convenience. So the cell phone is something which is actually having the disturbance in sperm motility and the normal morphology, antioxidant, oxidative stress, and the psychological stress. It is also a very important environmental toxin. People are always stressed at work, at home, at life, with variety of issue, real issue and the imaginary issue. And what we say, what I started, we have to be peaceful with ourselves. This is the ME study, which again characterized that it is
So as expected, Sadhana, you have proven true to your wisdom points, a very, very clear take-home message, a very, very clear viewpoint on environmental factors which are today affecting the infertility. And it is a matter of grave concern for all of us, for all the gynecologists. And somewhere, somehow, I think the social stress of life needs to be smoothened out for infertility factors to reduce. Manju Madam, would you like to add on something?
I don't want to add on, but it was really so nice. All the factors she has taken and described so beautifully and very clearly. Sadhana, बहुत अच्छा, बहुत बढ़िया. In detail, all the points were so clarified. Thank you, Sadhana. Thank you, Monica.
Thank
you, organizers, for giving me this opportunity. And all the best for panel.
Ma'am, thank you so much for chairing the session, Manju ma'am and Jyoti ma'am. Thank you for sparing your time. Thank you, Sadhana ma'am, for an enlightening talk. It was almost covering all the topics which we wanted. Thank you so much for accepting our invitation. We now move forward to the next academic session, and the chairperson for this session is Dr. Anita Sagarwal ma'am and Dr. Ma'am. The topic is optimizing outcomes of infertility treatments, and speaker is Dr. Kanchan Sharma, ma'am. I request Anita ma'am is the president of the Forum of OBGYNs in the South Delhi. She is the chairperson of the Public Awareness Committee of the ICS CSP 19 to 21. She is the past chairperson of the Adolescent Health Committee. She has been awarded a gold medal in AOGD. She is the executive member of AOGD from 2017. She is also an executive of the NARGI Delhi. She is an invited member of the Women's Cell of Violence Against Women, an advisor to the MPP committee of Fogsi, the master trainer of the core group of Dhira by Fogsi. She is a certified UNICEF GBV trainer, a member of the Safe Motherhood Committee, then a national faculty with IMA and the Government of India. We welcome you, ma'am, to chair this session. Bitu ma'am is in an emergency and she will not be able to join. So I request you to please introduce our speaker, ma'am.
Thank you, Dr. Monica, for the kind introduction and also for coordinating this whole webinar so well. Really, you people are such hardworking people, and you're really taking our Public Awareness Committee to heights. And also, I'd like to thank Dr. Priyankur, who is our chief and who's always taking care of all of us. So now after listening to the wonderful lecture of Dr. Sadhna Gupta ma'am, we have yet another one of the gems and jewels in the field of obs and gynae, rather I'll say infertility, Dr. Kanchan Sharma, who comes from Kanpur, our North Zone. And she is a very well decorated person with so many awards to her credit. Fogsi Achievers Award, Pratigya Social Impact Award, Empowered Woman Award, then Nari Ratan Samman and Corona Warrior Award. She worked so hard in Corona times also. And Nari Suraksha and Nari Samman Award from Police Commissioner of Kanpur also. So police also recognizes her so well. And she's also had the Lifetime Achievement Award from a Kanpur Obs and Gynae Society. And she has organized various national and international conferences. And she is an ART specialist, and she's been trained from our country as well as from Netherlands and France, and our country from Agra, from Mumbai, and as well as from our Delhi AIMS. So I think there's so many other things to tell about her, but she has such a wonderful topic to talk about. So I shall request Dr. Kanchan Sharma, an ever smiling, a wonderful, beautiful person, to go on with the lecture.
Thank you, Dr. Anita ma'am, our wonderful chairperson, for the nice words. For me, I'll be always obliged. First of all, my sincere regards to our visionary, hardworking president, Dr. Rishikesh Pai sir, and our chief guest, Dr. Usha Sharma. She is Padma Shri and very loving, always blessing, and she is my mentor and guru, and thanks always for her blessings. Dr. Manju Shukla ma'am, always blessing, very sweet, and my sincere thanks to the dear Priyankur, who is the chairperson of Public Awareness Committee, and his two right hands, Dr. Monica and Dr. Shatabdi, whom we are seeing that they are conducting all the panels. Very good. Dr. Sadhna Gupta, my sincere thanks and regards. You covered all the things very nicely. And now coming on the topics. Should I share the screen?
Yeah.
Yes, please.
Okay.
Ma'am, are you facing any difficulties in sharing the screen?
Yes.
Ma'am, just click on the bottom, share screen.
Yes, yes, because just before starting, I have seen, I have opened my this
Presentation.
presentation.
Yeah, ma'am. Do one thing. Open your presentation first.
Just
Then come to the Zoom screen. Come to Zoom screen. Then click on
डॉक्टर कंचन उसको छोटा कर लो, पहले एस्केप करके थोड़ा छोटा कर लो, then we'll be able to see all
हो
the.
जाता है। एक मिनट, जस्ट कुछ ना,
Yeah.
आई थिंक इसमें एक ये वाला हमने खोल दिया था जिसकी वजह से हो रहा है।
स्क्रीन को फुल स्क्रीन से हटा लीजिए, then you'll be able to see all the icons.
I think now this will अब हो जाएगा। अभी just before starting this I did it और हो गया था easily again. Post attendee.
अभिषेक, ये तुम्हें भेज सकती है कंचन क्या?
नहीं मैडम, हो जाएगा मैडम, हो जाएगा, बस एक मिनट। It never happened like this. एक बार मैं थोड़ा सा आउट होके दोबारा आ रही हूँ।
Sure, ma'am. Ma'am, just one thing. If you face any difficulties,
बस एक बार
हाँ, okay, ठीक है मैम.
Just leave it.
Okay.
I think in future we shall have everyone's slides also on web.
हाँ, तो पहले सारी slides आ गई थी even then.
Yeah. नहीं, वो आप या तो छोटा कर लो ना स्क्रीन को, तो आपके आइकॉन नहीं दिख रहे होंगे, तो then you will be able to see. आपने सेव किया होगा ना?
हाँ, this is saved and वो खुल भी रहा है। आपका वाला छोटा हो गया है, just दोबारा से शेयर स्क्रीन।
अभिषेक को भेज दो।
आ गया।
Okay.
आ गया।
Okay.
आ
Yes.
गया।
Perfect.
आ गया दिखला?
Yes.
Yes, congratulations. Right. We can see Dr. Kanchan.
Now it is moving.
Perfect.
Right.
Okay. Thank you. And I am audible also, na? So my topic is optimizing IUI success. I'm audible, Dr. Anita, madam?
Yes, you are. Very nicely audible.
Optimizing IUI success. Because nowadays, as Dr. Sadhna madam has discussed, there are a lot many problems in fertility because of environmental factor, lot many factors. So patient of infertility are increasing, and this is our duty that the patients who are coming to us, we should optimize continuously our treatment. The IUI is the most easy process for the fertility enhancement, and for that, even by the after ART rule, we have to do the registration. Now the level 1 registration that should be done for the IUI lab also. So what are the factors many co-founders ground for the discussion? These are for enhancement of the results of the IUI. We should consider the age, the duration of infertility, about the semen quality, about the semen preparation, about the timings of the IUI. There are a lot many discussions about the TLC. Should it be done? There are a lot many discussions about the number of insemination. Many say single insemination, others say 2 inseminations. Mild ovarian hyperstimulation should be done or not. What are its indication? Many suggest there are a lot many discussions about whether 15 or 10 minutes bed rest should be given after IUI procedures or should not be given. So patient selection is very important for us. It is seen that maximum success rate is there if age is less than 25 years, and maximum conception occur if it is less than 30 years, and success rate is little less when it is more than 35 years, and increased age of the male partner can adversely affect the outcome. So these factors, age factor is very important. This is a table which shows that IUI seem to be a poor treatment option for women over the 40 years of age. Usually now we are taking 36 or more, because as the age increases, results of IUI, they are reduced, and we, if the tubes are patent and other factors are not there, we, after 3 cycles of IUI trial, we suggest the patient for IVF. First of all, we see that all the methods, all the things are optimized or not. Patient selection, duration of infertility is very important for IUI. If a patient comes to us, higher rate is of the success is more if infertility duration is less than 3 years, and if duration is less than 6 years, conception rate is 20%, while if the duration rate is more than 6 years, conception rate again fall down to 10%. So duration of infertility and age, both are very important factor. Other patient selection, duration of infertility, age less than 35 of the lady with the good ovarian reserve give comparatively better results. At least one patient fallopian tube, patent fallopian tube should be there with good tubo-ovarian relationship. This is very important. And short duration of infertility, if it is less than 5, these are the selection criteria for IUI procedure. Actually, there is lot many discussions. How many cycles should be done for IUI? Pregnancy resulting from IUI occur during the first 3 to 6 treatment cycle. They are maximum. Most women conceive within 4 to 6 cycle of IUI. So cycle fecundity decline by half to 2/3 thereafter. Usually, I may ask to all of you that how many cycles you give for a trial of IUI. The NICE fertility guidelines says that up to 6 IUI cycles for the patient with unexplained infertility and male fertility and the cervical factor and minimum 2 mild endometriosis are to be given. While in our practical aspect, we have seen that I do give only 3 cycle. After that, I have to suggest for IVF. Otherwise, patient start running and they don't believe that I am getting pregnant. The cause of infertility is very important. Maximum success for ovulatory dysfunction is followed by male subfertility. The best result in anovulation and unexplained infertility is of the IUI. So we have to see the factors. What are the factors? Tube should be patent. They should be good, in good condition. Minimal male factor can be covered by proper washing. So there was a trial in Barnhall Clinic 1999. They say that high pregnancy rate is with the unexplained infertility, and that is 9.2 to 22%. While with the ovulatory dysfunction, this is 19.2%. Modest pregnancy rate is by the cervical factor, which is 16.4%, and the poor pregnancy rate is in case of endometriosis, immunological infertility, and the male factor. The best pregnancy rate with ejaculatory disorder is 13.3% only. It is very important what stimulation protocol you follow in IUI. Many I have seen they are giving just the natural cycle plus IUI, but the success rate is very low in these cases, 3.3%. So you should always add these with the stimulation. In this, Then we add clomiphene citrate plus IUI, the success rate is only 9.5%. While if we add clomiphene citrate with HMG, it is 13.3%. And the best success rate is seen when these induction is to be done by HMG, and that is 17.26%. So stimulation criteria should be followed very properly. Number of follicles. It is seen that number of follicles per pregnancy per cycle is very important. There are higher pregnancy rate with 3 pre-ovulatory follicles at least. At least we should see that there should be at least 3 pre-ovulatory follicles. Otherwise, we will be getting very poor results. Follicular dynamics is very important. Our aim is pre-ovulatory follicles at least 2 to 3 of equal to or more than 16 mm. Endometrial thickness again is very important. If the endometrial thickness is less than 6 mm and poor blood flow, then the success rate is very poor. Nowadays, we say that color Doppler has a very important role in the success of IUI. Is in functional maturity of the follicles and the endometrial blood flow can be seen by the color Doppler. If the follicles is more than or equal to 16 mm, if there are more than or equal to 3/4 vascularity of the follicles is seen in the color Doppler, RI is less than 0.5 and PSP is equal to or more than 10 centimeter per second, then we can go for IUI. This is a very good indicator. Volume, if we have a 3D and 4D, nowadays this facility is there of the 3D and 4D. The volume of the ovary, if we see that is if more than 3 to 8 cc, and cumulus oophorus, that is seen in many times in the ovulatory follicle, that give a definite indication of ovulation and our success rate that increases. And we also see the VI is 6 to 20 and FI more than 35. Then that is the ideal time. What is the ideal time of SCG? That is the ideal time of SCG. And endometrium, it is also to be seen by the color Doppler before the IUI. If endometrium is more than or equal to 6 mm, grade A or B, and even zone 3 to 4, blood flow is there and RI is less than 0.6 and PI is equal to or more than 2, then this gives a good result. And uterine artery color Doppler should also be seen. Here the RI is less than 0.9 and PI is less than 3. Then it gives a good result. By the 3D volume of the endometrium, if taken, is more than 3 cc. These all factors. Now, because the color Doppler and the advanced type of the machines are there, we can see all these parameters and they give us a good result, and they assure us that we will have a good result of IUI. If more follicles, risk of OHS are there, and the multiples in IUI. In this case, if the follicles are more than 3 of more than 16 mm or more than 8 follicle of more than 12 mm, either we have to convert these cycles into IVF cycle or we have to cancel the cycle. Otherwise, the patient will go into OHSS and we will have a problem. Total motile sperm count and motility cutoff is very important. This, if it is 10 to 20 million per cycle, 18.29% is the success rate. 5 to 10 million, 5.63% is the success rate. While with the less than 5 million, the success rate is very poor. So ideal TMSC should be 5 to 10 million. If it is less than 5 million, counsel the patient and do the ICSI. By the ICSI, you inject one sperm and in a one oocyte. That increase your success rate even with the less sperm count. So cutoff for IMS That is, IUI should be a treatment of choice in case of male subfertility, providing an insemination motile count, that is IMC, of more than 1 million can be obtained after the sperm preparations. So, best predictors, IMC after washing and the sperm morphology by strict criteria are the most valuable sperm parameters to predict IUI outcome in the male subfertility. This is a diagrammatic representation which indicate that we do IUI in the male factor subfertility. There may be reason of oligozoospermia, maybe asthenozoospermia, maybe teratozoospermia, and this may be combined with the tubal factor or non-tubal factor. If there are combined with the tubal factor, of course, we have to change this procedure to IVF and the ICSI, that is to be done. While if there are no tubal factor after washing, if IMSC is more than 1 million, then after 3 to 4 cycles of IUI, if there is no success, we can convert this to IVF or ICSI procedure. While if this count is less than 1, then or more than 4% of the morphology is good, then even then we can try for 3 to 4 cycles of IVF and later on can convert with ICSI. If this count is less than 1 and morphology is very poor, less than 4%, then directly ICSI is advised. So sperm preparation is a very important, that is to be optimized, that depend upon the semen character. This is my lab. I am doing the sperm preparation in centrifuge machine. Swimmer commonly used. Density gradient can also be used and show better quality. Insufficient evidence to recommend any particular technique over the other. Thus, what is the sperm wash and IUI interval? Many persons, they ask that what should be, there is an interval between the sperm wash and IUI. It should be less because there will be exhaustion of energy sources in the sperm washing medium by the motile spermatozoa. And there is premature capacitation of the vast motile spermatozoa. So timing of insemination are again important. There is a fixed protocol that shows that single plant insemination 36 to 38 hours post HCG is mostly used, while some discuss about the double insemination. The first, they are doing 24 hours post HCG and second 48 hours post HCG. There is variable protocol. TVS 36-hour post HCG is done. Some do, and they see the ovulation. If the patient has ovulated, do the single IUI, and if not ovulated, IUI at once, and again after the 24-hour later. But nowadays, I especially prefer single IUI. This is a diagrammatic representation which shows that I have just shown the color Doppler matching. According to that, if we go, we get the maximum success rate. Postponing the IUI until the observation of the follicle rupture may yield a higher pregnancy rate, that is even 25%. Again, there is a lot many discussion, double versus single IUI. So in my experiment, no difference in pregnancy rate between single versus double. That was again seen by some foreign workers. An exception suggested is if the TMC is less than 1 million or on insemination day, a second IUI can be offered within the next 24 hours. What are the effects of timing of intrauterine insemination in relation to ovulation and the number of inseminations on cycle pregnancy rate in common infertility etiology? The study, there was a study, very important study, in the human reproduction journal, it says that which included 1146 first stimulated cycle in infertile couple due to male factor, anovulation, or an unexplained infertility. That shows that single IUI timed post-ovulation gives a better CPR when compared to single pre-ovulation IUI for non-male infertility. Whereas for male factors, pre-ovulation double IUI gives a better CPR. So single and double, there are few different indications when compared with the single IUI. There are many discussions. I always heard saying people what type of catheters you should use. The new comers which are starting their lab, they are always asking what type of catheter does it affects, what are the different problems, what is the difficult IUI. There is no significant difference in pregnancy rate when using the softer Wallace catheter or less pliable Tomcat catheter during IUI with the standard gentle non-touch technique. These are the few various IUI catheters which are being used. Macular IUI cannula, Cook soft pass catheter, Gynetic catheter, Tomcat catheter, Wallace artificial insemination catheter. Some have a radio tip, and some have a, which can be very easily seen in the ultrasound machine during ultrasound, and some have a hard tip catheter which can be passed in the steno, even hard cervix. There is a lot many discussion about the inseminated volume. There's no difference in pregnancy rate when the inseminated volume varied from 0.3 to 1 ml. It should be 0.3 to 1 ml. IUI technical aspects. Aseptic technique to avoid the genital infection should always be used. It should be gentle and atraumatic. Products of local tissue reaction to injury may be hostile to spermatozoa. So we should always try that there should be no local tissue injury. In this, what I do in the pre-insemination cycle, we do a dummy transfer and see that all the tract is clear, whether it needs any dilatation in the pre-tract, it can heal in the further coming cycle. What are the steps of insemination? Partially filled urinary bladder should be there. Patient lies in the dorsal position, sometimes with hip and knee flexed and hip slightly abducted. Gentle and atraumatic clean, and traumatically clean the cervix with a saline soaked swab. This is very important, very gentle cleaning. Introduce IUI catheter through the cervix, no touch to fundus. It remains a bit away from the fundus. Slowly inject 0.3 to 0.5 ml of the processed semen and slowly withdraw the catheter. This is the IUI procedure. What is difficult insemination? Easy, that occurs in 80%, while there are few difficulties which are coming in 20%. Greater resistance during the catheter negotiation, that happens in some cases. So in these cases, you need a harder catheter and slight cervical dilatation. That is to be done because as I do the dummy transfer and see in one cycle before, that can be done, and the cervical dilatation can be done one cycle before. So why difficult insemination? There are few, when the internal os to left of external os is 80%. This is a canal that is seen. When internal os to right of external os is 10%. When internal os is in the straight line with external os, then difficulty is very less, that is 10%. There may be hyperextension, maybe anteverted, retroverted, or uterus, or there may be external os which may be flushed. These all cases may suffer a bit difficulty. Difficult IUI, how to avoid and what to do. Keep the cervix centrally in vagina by speculum manipulation. External os in the transverse axis of the vagina should be there. Slight traction of the cervix with the Alice tissue forceps can straighten out the uterocervical angulation. And use of forceps usually do not reduce the pregnancy rate. Many may say that this use of forceps may reduce the pregnancy rate, but this is not the fact. Ultrasound guidance is very important because we have to measure the uterocervical angle beforehand by the ultrasound. IUI and molding the catheter accordingly increases the clinical pregnancy rate. In the pre-cycle, we can do the hysteroscopy and cervical dilation. Trial IUI enables the clinician to assess the degree of difficulty that I have already discussed. Assessment of the depth and the shape of the uterus, selection of the optimal type of catheter, mapping the easiest and the least traumatic entry into the uterine cavity, and identifying the cervical stenosis. This is very important that in the pre-cycle, either by the hysteroscopy or by the other method, by the ultrasound proper, you map, is there proper angulation, what is the depth, rather our os is stenosed or not. So ultrasound guided IUI, many say that whether IUI should be done under ultrasound guidance or ultrasound is not needed. Ultrasound guided IUI has been tried. It is not found to increase the pregnancy rate except in difficult cases, difficult IUI. What is your recommendation about the bed rest after IUI? Many are asking to us. We are giving a 10-minute bed rest, which has a positive effect. Although nowadays we discuss it that it doesn't have a lot much effect, but because just to counsel the patient after the procedure, patient just lies, she is in a bit agony. So always we are giving 10-minute rest, although it doesn't have a great effect on its success rate. What about the time intercourse after the IUI? My patients are always, they are asking, ma'am, ab IUI kar diya, whether we should take a rest or we should not do intercourse in this cycle. But the timed intercourse within 12 to 18 hours period useful in IUI with low number of motile sperms inseminated. Always in those cases, this is more helpful. Luteal phase support. Most centers provide luteal support. However, no evidence to support, not needed. That is in ASHRAE. But we all are giving luteal phase support because we induce, we create a difference in the hormonal milieu, and we are giving the progesterone support. Agonist and antagonist use. Antagonists are being tried in PCOS to combat the premature LS surge. An increase in pregnancy rate shown, but an increased risk of multiple pregnancies are there. So such patients should be counseled for IVF, where there are more follicles due to risk of OHSS and multiple pregnancy in IUI cycle. No evidence to support use of agonist or antagonist as they are not cost effective, as ASHRAE guideline says. If pregnancy rate per cycle goes down, then we have to be very alert and think what is the reason behind the low pregnancy rate, whether this is a media, whether this is our incubator, do you have any infection? We have to check the VOCs, we have to check our all the procedure, lab persons, difficult in IUI trial, stimulation protocol to be changed, and the baseline scan should be very proper before the stimulation. So to conclude, careful selection of the couples and the maximum 3 to 6 cycles are to be used. Good understanding of the physiology of control ovarian hyperstimulation should be there. Use of gonadotropins in IUI, but avoid the multiple pregnancy should be there, that we should keep in mind. OHSS. Well-timed single IUI is the best. Avoid endometrial injury, and strict sperm cutoff for IUI should be there. If all these adhere to cost-effective before IVF in the young couple with a good reserve. So all these policies, if we follow, so we can advise this IUI to young couple because this is very cost effective, and many are willing, they are happy with IUI in comparison to IVF. This is my lab, and thank you very much. My sincere regards and request to bless me for NCT committee. Fogsi, thank you very much. No,
Anita ma'am.
Thank you so much, dear Dr. Kanchan. Wonderful lecture, truly very updating, stimulating, interesting, and you really made IUI sound so simple and crystal clear. But one thing is that, as you said, the age factor, less than 25, more chances, 20%, and less than 30. But as you know, now the working girls are there, so they tend to get married really late, and they come late to us for these infertility issues. So maybe this data is going to change with time, because in our time, we used to girls getting married even, below the legal age. So
all
that is how
girls now get married after the 28, 30 years. That I see. Yeah.
Absolutely. And also that bladder full has to be there.
Partially.
Otherwise, partially full. So really, thanks. Very great lecture, and I think we learned a lot. So if our seniors or others have any queries or they want to add, please go ahead. Usha Sharma ma'am is there with us. And
Sadhana ma'am is there, ma'am.
Okay. So otherwise I'll say, because we have such great people here today, from Dr. Usha Sharma ma'am to Dr. Manju Shukla, all the great chairpersons, guests of honor. So I'd like to say something that, because today we're really walking with the, dreamers, the believers, the courageous, the planners, the doers, the cheerful and the successful people, with their heads in the sky yet feet on the ground. And really their spirits have ignited fire within all of us, all the people, all the listeners who are listening to them, and really made our world much better and beautiful and wonderful than it was before we came to this webinar. And all credit goes to Dr. Monica and Shatabdi for bringing them all here on this platform.
Really.
Thank you so much for giving me also the opportunity to listen to such great orators. Thank you, Dr. Kanchan.
Thank you very much.
Thank you, Kanchan
ma'am, Dr. Monica and Shatabdi.
Thank you,
Thank
ma'am.
you so much, ma'am. Thank you for accepting our invitation. Thank you, Anita ma'am, for chairing this session. It was an excellent deliberation with a lot of take-home messages, ma'am. Thank you for accepting our invitation, and we wish you all the best.
Thank you so much.
Let's move on to the next session. I hand over the baton to Shatabdi to please carry on with the panel discussion.
Thank you, Monica. Once again, a very good evening to everyone. Thank you, Kanchan ma'am, for the wonderful talk, and thank you, Anita ma'am. Whatever you say is always inspiring for us. So we'll move on to our panel discussion. We have a very interesting panel coming up. It's on the case-based discussion. We'll have some case-based discussions on how to approach a couple with infertility. We have two wonderful moderators with us, Dr. Rajul Tyagi ma'am and Dr. Preeti Jindal ma'am. And our expert panelists for the session are Dr. Ekika Singh ma'am and Dr. Poonam Lumba ma'am. Abhishek, can we have Dr. Rajul's slide? Yeah. Ma'am, Dr. Rajul Tyagi is the president of the Association of Private Gynecologists of Lucknow. She is also the ISPAT Managing Committee member, Vice President of the ISPAT UP chapter. She is the director of Javitri Hospital and Test Tube Baby Center at Lucknow and Javitri Institute of Paramedical Sciences. She also has been a committee member of the Endometriosis Committee. She has had various trainings and various awards to her credit. Welcome, Dr. Rajul ma'am. Our next moderator is Dr. Preeti Jindal ma'am. Dr. Preeti Jindal ma'am is the director at Touch Clinic Mohali. She is the Advanced IVF High-Risk Pregnancy Cosmetic Gynecology and Laparoscopic Surgery Center director, and she's a specialist in all of this. She has been the past president of Mohali Obs-Gynae Society, also the general secretary of the Indian Society of Aesthetic and Reconstructive Gynecology. Ma'am has various awards to her credit and more than 50 national and international publications to her credit. Welcome, Preeti ma'am.
Thank you.
Our expert welcome ma'am. Our expert panelists for the session are Dr. Ekika Singh ma'am. Dr. Ekika Singh is a senior fertility consultant. She has been awarded with the Champion of ISAR in 2020. She also has won the Wonder Foxian Award by Fogsi in 2020. And she has held various official posts like the Secretary of MAU Obs-Gynae Society, also the member of Managing Committee of ISAR. Welcome, Ekika ma'am. Our next expert panelist is Dr. Poonam Lumba ma'am. Dr. Poonam Lumba ma'am has been the chairperson of Haryana chapter of ISAR between 2011 and 2015. She has been the ex-president of IMA Ambala Cantonment, also honorary librarian and executive member of ISARS. She is the director of Lumba Hospital and IVF Center at Ambala. She also has been awarded with the President's Gold Medal at the university level. Welcome, Poonam ma'am. We have 8 panelists with us who are all experts in the field of infertility. We have Dr. Monisha Singh. Our first panelist is Dr. Monisha Singh. Dr. Monisha is consultant at Sarojini Hospital and Parul Hospital at Varanasi, and she is the active member of Young Talent Promotion Committee between 2020 and 2023, and also the winner of Fogsi ISAR YTP MTP Award in 2021. Welcome, Dr. Monisha. Our next panelist is Dr. Bhavana Ba. Dr. Bhavana ma'am is the director and unit head in the Department of Reproductive Medicine and IVF Center at Cloud9 Hospital, South Delhi. She is also the director, Department of Reproductive Medicine and IVF at Noida. She is the ex-director of Max Healthcare and also the ex-director of BLK Max Delhi. Welcome, Bhavana ma'am. Our next panelist is Dr. Niharika Tyagi. Dr. Niharika is the consultant infertility and fetal medicine specialist and head of fetal medicine and HRP unit at Javitri Hospital. She has held fellowships in fetal medicine from Chennai and also the fellowship in critical care obstetrics at Safdarjung Hospital from New Delhi. Welcome, Dr. Niharika. Our next panelist is Dr. Manisha Bhagat. Dr. Manisha Bhagat is a center head and chief consultant and consultant in IVF and infertility in Indira IVF, Jammu, India. She's a consultant. She has been the consultant of Jammu and Kashmir Health Services between 2011 and 2017, and also a consultant IVF and infertility specialist at Genome, the Fertility Center between 2018 and 2020. Welcome, Dr. Manisha ma'am. Our next panelist is Dr. Sapna Khullar ma'am. Ma'am is the professor and head of department in the Department of Obstetrics and Gynecology at ASCOMS. Also the director of Green Coat IVF Center. Ma'am is a gynecologist, a urogynecologist, and working as an infertility specialist and as a medical teacher for more than 15 years. Welcome, Sapna ma'am. Our next panelist is Dr. Sonu Bhalara ma'am. Ma'am is the director of ART Fertility Clinics, gynecologist and fertility specialist, and presently the director of ART Fertility Clinics at Gurgaon, Haryana, and also the secretary of Haryana chapter of Indian Fertility Society. Welcome, Sonu ma'am. Our next panelist is Dr. Shanujit Kaur ma'am. Ma'am is the associate director in the Department of Gynae at Cloud9 Hospital, Chandigarh. Her areas of interest are infertility and high-risk pregnancy. She has been the ex-convener of Chandigarh Obs-Gynae Society and also the treasurer of Chandigarh Region Menopause Society and ex-executive member of IFS Chandigarh chapter. Welcome, Shanujit ma'am. And our next panelist is Dr. Aditi Gupta ma'am. She has been trained in infertility and IVF and advanced laparoscopic surgery by Fogsi accredited centers. She has a working experience of more than 18 years, and she has had various presentations and posters in state, national, and international conferences, and presently working at Ashirwad Fertility Center and Metro Hospital, Haridwar. Welcome, Aditi, Dr. Aditi, ma'am. Yeah, I think I'll hand over the dais to Dr. Rajul ma'am and Dr. Preeti ma'am to carry on the panel, and we're looking forward to a very interesting discussion.
Thank you, Dr. Shatabdi, and thank you, Dr. Manisha, for giving this opportunity. Should I share the screen because the slides are with me?
Yes, ma'am. Please, ma'am.
One second. I'm just start sharing. One second. On the share screen, I share some.
Ma'am, it's on the bottom side. There is a green button, share screen in between.
I know, I have clicked it, but it is not showing my. Okay, first I think I'll have to make myself. One sec. What is happening? No. When I write share screen, it shows. One sec. Are you able to see?
No, ma'am, not now. Just do one thing, ma'am. Have you opened your presentation?
Yeah, I have opened my presentation.
Then come to the Zoom screen.
Okay, I am on the Zoom screen now. Yes.
Click on the share screen. The second window get opened. It's the small window.
Okay, I think I can see now. Yeah, can you see it now?
Yes, yes, ma'am. Perfect.
So
Ma'am, can you just make it full screen?
Yes, I'll do that. Yeah, and I'll start the screen share.
Click on that slideshow.
Yeah.
Yes. From beginning.
Right, perfect. So is Rajul, Dr. Rajul there?
Ma'am, just one thing that might be your this Microsoft this PowerPoint version is low, the older one. That's why we can't see the full screen.
What are you able to see? On my screen, I can see.
Yes, ma'am. But the version is lower one. The older version you are using. That is the compatibility issue with the Zoom.
All right. So what do I do?
So ma'am, either you can carry on with this mode
I'll
only.
just carry on. I'll just carry on. It doesn't matter because
yes, ma'am. So just exit on this slideshow mode.
Okay.
And click on this normal screen. Yes, ma'am. Please go ahead.
Okay.
Yeah.
So
I have joined late. Sorry.
Dr. Rajul is there?
Yeah.
Hello,
but
Dr.
little
Rajul.
bit some problem of connectivity problem is there. So I will take it still 2-3 minutes. So tell doctor to start the panel. I will.
Okay. So should I start the panel? I'm Dr. Preeti. Hello, Dr. Rajul.
Yeah, Dr. Preeti Jinder, please start. Or meanwhile, I will connect myself.
Okay. So we are going to discuss a very beautiful and interesting panel, and we have very good list of panelists here, all very experienced and star people here. So we are going to discuss two cases. The first case will be in which we will try to cover the management up till IUI, and in the second case we'll go for the advanced thing. We'll cover it very fast because I know it's already 7 o'clock. So we'll try to finish it in 20 minutes if possible. All right. So our first case is one 37-year-old nulli gravida engineer with regular cycles, married since 8 months to 39 years old engineer. They have no.
Preeti, we can't see the case, Preeti. You select the first slide.
You cannot see the case. You cannot see the slide?
Ma'am, exit on the presentation mode. Ma'am, exit the presentation mode. Click on the normal PowerPoint screen. Okay, click on the first slide and click on next. Arrow key next.
One sec. I will have to stop sharing. Let me just stop sharing.
Not required, ma'am.
Okay. So because on my screen, I'm not able to.
Then click stop share.
Is it better now?
Yes, ma'am. Perfect. So click on the first. Yes, ma'am.
Shanujit, can you see now?
Yeah, this is the first slide, Preeti. And going to
yes, it is moving.
See the case? Case 1. Yeah, perfect.
Right. So 37-year-old Nalli Gravida engineer, married since 8 months to 39 years old engineer, no coital difficulties, no comorbidities. On physical examination, there was nothing good detected and everything was absolutely fine. So patient came to one of our panelists and they did the semen analysis and they found asthenospermia in this patient. So my first question is to Dr. Monisha Singh. Is Dr. Monisha there?
Yeah.
Yeah. Hi, Dr. Monisha. This couple comes to your clinic and then we can see there is a male factor. And otherwise, how do you evaluate this couple? Yes.
So thank you for having me. And definitely, given that they have married in a very late age and they have been trying for over 8 months now, I am hoping. But we really need to assess the complete history again. We need to evaluate through the investigations and prior treatment they might have taken, and especially the preconceptional counseling, if not done, should be done in this case. And really assess over and over again, and semen analysis, if there is, then take back to the male history over again to find the root cause. I'm assuming the engineering part and the late age and definitely certain history that might be there that can affect them.
Perfectly, correctly answered. So now if we look at her age, she is more than 35 years. So if a woman is older than 35, she should receive an expedited evaluation and undergo treatment after 6 months of failed attempts. So our patient qualifies in both these categories. So we really need to help her with her conception part. So if a woman is less than 35 years, we can wait for 12 months. If she is more than 35 years, then if she has not conceived in 6 months, and if more than 40 years, any woman comes, then we should start investigating immediately. Now, the next, so basic infertility evaluation. Dr. Manisha, would you like to read this chart?
Definitely. So overall, as we all know, the history has to be taken thoroughly, because most of the cases, the causes can be ruled out through history and examination itself. The pre-pregnancy evaluation, any additional evaluation that has been there, as we can see with the age, there can be chances of ovarian reserve. We need to assess her tubal and uterine factor also. And for the male, the history, semen analysis, and so on. His hormonal analysis, if need be, should be done.
Correct. And in pre-pregnancy evaluation, we should not forget her HB electrophoresis to rule out thalassemia, and also her Rh negative status and rubella and varicella IgG. If we have time, we can immunize her. The next question is to Dr. Niharika. Hello, Dr. Niharika. Is Dr. Niharika there? All right. So we move. The question was, what are required investigations for this couple? So as already stated, when we have to investigate this couple in women, we need to do her fertility hormones, which includes her FSH, LH, AMH is very important, estradiol levels, ovaries. We should do a baseline ultrasound, and if possible, on day 2, day 3, we should take a score of her AFC count. Her uterine and fallopian tube estimation is very important by HSG or SSG and other hormones like prolactin and thyroid. So even if the semen count is less, we should simultaneously also evaluate the women also. We should not be that we waste our time for 3-4 months in the male factor and then return to the female factor, because the time is of essence here. So the potential contributors to subfertility are low ovarian reserves, increased age, lifestyle factors already discussed by Dr. Sadhna ma'am, tubal factors, fertilization defects, there could be implantation defects, metabolic disorders, endometriosis, fibroid adenomyosis, and sperm abnormalities. All these questions were for our other panelist, but she's not there, so I'm covering it. So diminished ovarian reserve, we can measure by AMH values, which if less than 1 nanogram per ml, we should be alert. AFC count less than 5 to 7, FSH values more than 10 should alert us, and a history of poor response to previous IVF cycle if happened earlier. My next question is to Dr. Bhavna Banga. Dr. Bhavna, are you there?
Yes, I'm there.
Welcome, Dr. Bhavna. So what is important in history taking and physical examination in a couple with male infertility?
So if you're going with this particular case, I would ask for a history of specifically for smoking and any addictions. And where the lifestyle measures are concerned, I would ask that what kind of profession the husband is. I know he's an engineer, but what kind of engineer is he? Is he dealing with spaces which are high on humidity and on temperature? And where the local examination is concerned, very specifically to rule out for the testicular size and the varicocele, which are the most common cause of oligoasthenia spermia.
Perfect. So according to WHO 2010 thing, asthenozoospermia means less than 32% progressively motile sperm or less than 40% total motile sperm. And oligozoospermia means concentration of sperm less than 15 ml per ml of 15 million per ml of seminal sample. Causes as rightly elaborated by you, and some few more causes could be any history of chemotherapy or radiotherapy, any unknown febrile illnesses, or any history of trauma. Also, genetic evaluation is important in such cases, especially for microdeletion of Y chromosome, cystic fibrosis, fragile X syndrome, and Klinefelter syndrome. So, Dr. Manisha, the next question for you, what are the treatment modalities for this couple?
Hi, good evening. So like this patient, both the couple age is 37 and 39. So first of all, we need to educate the patient what they are dealing with. So first of all, we need to counsel the patient, because the management cannot be like we are telling them and they are following. They have to understand what we are dealing with. This is an advanced age couple which is dealing with advanced stage complication. The male has oligoasthenozoospermia. So first we need to look out for two major causes which nowadays males suffer. First is obesity, whether he is fat, what kind of habits is he having, and second is whether he goes to gym. Now there are a lot of guys who goes to gym and they abuse testosterone because steroids are given to build muscles. So we need to take these two pointers in history which was left, and secondly you need to counsel them for lifestyle modification. They have to decrease stress levels in their life. They need to modify their diet. They need to reduce weight if it is there. And thirdly, the most important thing for male factor infertility, which actually works, is the role of antioxidants. They have to be put on lycopene, coenzyme Q10. That helps to build that helps to overcome the oligoasthenoteratozoospermia part. And if any infection is there, you need to look out and give antibiotics for that. And after that, you assess the semen analysis after 2 months, and simultaneously you treat the female partner also and advise lifestyle modification diet to her also.
Yeah, and there's just one more thing that I'd like to add is which the frequency of intercourse in such couples is not likely to be really high. So they would save it for the ovulation days. And on that day, they would get the most dead sperms when they need the most active. If they have a long abstinence before the fertile period, so they actually do that ovulatory calendar thing and just mate only then. So I always ask the frequency, and I make it a point to explain them to have more frequent intercourse. And also, where do they keep the laptop? Is the laptop on the lap for India? So the laptop better be on the table and not on the lap.
And their mobile phones also.
And their mobile phones not in the trouser pockets.
Yeah. Correct.
Yeah.
Perfect. So my next question is to Dr. Sapna Kullar. Dr. Sapna, are you there?
Yeah,
I can see you. Yeah. So what is the latest WHO criteria for semen analysis?
Now, the latest criteria is 2021 revision criteria, and this is slightly different from the 2010 criteria, because the volume there it is in 2010 it is 1.5, but in 2021 the revised one it is 1.2. And volume is very important, because straightway from volume we get an idea, because I always say this semen analysis is a horoscope of the patient, because just from one volume we will know whether this is a case of obstructive or non-obstructive patient. So if it is volume is very less, maybe this patient is not getting secretions from the seminal vesicles, there is some obstruction. So if volume is less, somewhere at the back of our mind we think maybe we are dealing with a case of obstructive azoospermia. And pH, again, it is more than 7.2, but if it is less, it is more acidic, then we always think the alkaline seminal secretions are not reaching So maybe we are dealing with the case of obstructive azoospermia. And the sperm concentrations in 2010 criteria, it was more than 15 million per ml, but in the 2021, it is more than 18 million per. A slight difference is there.
Much to our relief, 15 was too low.
Was too less, yes. And total sperm count was more than 39 million per ml, but here it is 36. Even 36 they are considering normal, and total motility is 39 or 40%, progressive 32%. But here they have categorized into category A, B, and C. And in category A, that is more than 40% with forward progression. That is category A and B. It was in the 2010 criteria, whereas in 2021 it is more than 43%. Then again, when we talk about vitality, it was more than 58% live spermatozoa, but now they have decreased the vitality to more than 53% in the 2021 criteria. And morphology remains the same, more than 4%. And they have added some other things like fructose levels, because if fructose is there, good. If it is not there, we know it is obstructive. And this level should be more than 13 millimoles per ejaculate. Alpha glucosidase also should be there. Then zinc levels should be there. That is more than 2.4 millimoles per ejaculate. And the citric acid should be more than 52 millimoles per. And another thing is, if we happen to see Sertoli cells only, then we know this is a case of chromosomal deletions. That is azoospermia factor. Most likely it is A. But if we find arrest at the primary spermatocyte stage, then we think this is azoospermia factor B. So likewise, if it is a non-obstructive, if it is obstructive, then we think of this congenital bilateral obstruction of the vas deferens, and then we think of CFTR genetic testing can be done. That genetic testing, or cystic fibrosis can be an association.
Perfect. Very nicely answered. So we move to the next question to Dr. Sonu Balhara. Dr. Sonu is there. So Dr. Shanujit, maybe you would like to take this question. What are the various methods for preparing semen sample? Very clear cut.
Just the two most frequently used were the sperm wash, the swim up method, and one is a simple sperm wash. The little advanced one is the swim up method, and what we normally use now is the double density gradient. So because that's supposed to, but the only drawback which the WHO manual says about the double density is that it does add to a little ROS. By some mechanism, but that is the go-to method for us, the double density gradient.
Correct. So I think the next question is also for you. What ovulation induction protocols in IUI cycle would you like to use?
So Preeti, for this patient, no, she's 37 years and with oats, oligoasthenospermia. So for her, naturally, I would want to give her a little more stimulation. Like I'd go for multiple follicular development, which means my thing would be either letrozole plus gonadotropins or gonadotropins alone and IUI. So because natural cycles or only CC or letros, I would go with the letros plus gonadotropins straight away.
Yeah, but I don't know. But then if we look at her, if the tubes and everything open, so what actually prompts you to start gonadotropins if the eggs are forming well?
I'll tell you what. No, you know what? So when you're talking, when you're doing IVF and you're looking at Poseidons and you're looking at the ART calculators, so what strikes your mind is the probability of getting a good oocyte. So that's what they said. If you put her in an ART calculator at 37 with oats, I don't know the semen analysis exact parameter is not given, but the ART calculator would make out something like 12 oocytes or 10 oocytes to make one euploid embryo. So when you're doing IVF, you tend to extrapolate and you want to, that's my way of thinking for her. So I would want to make at least 3 follicles in an IUI cycle, like Dr. Kanchan just said. So maximum, if that's my way, I may be wrong, but that's what I think.
No, it's perfectly fine. But then, so what we normally prefer is that we would like to go with some either clomiphene or letrozole and do the follicular study, and we might give a little stimulus with gonadotropin. I'll come back to you, Dr. Bhavna, one sec. Yeah. So then we can add small dose of gonadotropin basically to improve the quality of the egg, and then move ahead with the IUI. But then, yes, you were trying to say something, please?
Yeah, Preeti, I have an opinion on the use of clomiphene in advanced stages. So we already understand that the ladies of an advanced age, so we are already at a suboptimal egg quality. When we add clomiphene in 10 to 15% of the cases, there is uterine thinning. So clomiphene always has got a lower pregnancy rate. So for an IUI cycle, and letrozole gonadotropin would be a better option over a
Correct,
clomiphene
correct.
into such
That is
patients.
normally most of us do. Clomiphene is just mentioned here because it comes in that protocol of mentioning it. Because many people still use clomiphene, but personally, I have to already given up on clomiphene. Most of us, I think, we use letrozole and we add this minimal stimulation protocol with gonadotropin on day 7 or day 9, depending on the size of the egg, and then we go ahead with the IUI. So all panelists are okay with this option, or anybody wants to add anything to it? All right. So IUI was very nicely covered in the last lecture. So we will not go into the details of it. And Dr. Aditi, are you there?
Yeah, I'm there.
Right. Hello, Dr. Aditi. So the question is the treatment
Hi.
of male infertility.
Look, it's a grossly, if you see it, seeing this patient at 39 years of age and male infertility, I think grossly we have to really go through the physical examination first, looking at the weight of the patient. And nowadays, overweight is always a problem for most of the couples, especially the sedentary lifestyle for the engineers, stressful life. So we really have to take the proper history, the weight, and the blood pressure, obviously. For the treatment point of view, for myself, I'm just talking about my work. Obviously, book says so many things, but first and foremost thing is exercise and the weight control, and stress and the lifestyle changes means even the night whenever they have to work all late in the night. So we really have to inform them the circadian rhythm and whatever good for their body. And then maybe semen analysis, obviously, rather than other blood tests are required, same as female. We do some blood tests also, routine blood tests. Then semen analysis is most important, I feel. Maybe two semen analysis we have to really see at least 15 days apart minimum, or maybe a month apart. And according to that semen report and other test reports, then we have to go ahead. Mostly semen, I in my practice, we see infertility, 80% infertility only. So what we see in semen reports is 60% semen reports are perfectly normal. They look like perfectly normal, all count normal, modality is fine. But when you do it in our center, we can make out the morphology. There's a morphology problem in most of them, and the active motile sperms are much lesser as compared to the slow progressive modile. So outside, a lot of technicians are doing, and obviously they don't have that much of maybe time, and their eyes are different than ours. So those things are very, very important point that we have to look at ourselves if we are doing in our lab, in our own setup. So that semen analysis is much more important. The CASA has come nowadays. Obviously, that is a very good support system for us, because we really have to do a cross check for that patient, because patients sometimes they don't feel that okay, they hear maybe their reports are wrong. So once the computer reports are there, so we can tell them, emphasize on them that okay, morphology is that much problem, and this much is a computerized report. We can cross check also. So these things are important. Then according to the report, we have to really see about the count, whether it is normal zoospermia or actinospermia. So actinospermia, we really have to obviously the weight reduction and exercise, the antioxidants we have to just pull in, and according to the problem we have to really see whether it is ectozoospermia or azoospermia. That's one.
Yeah. So depending on the cause, we will tackle the thing and we'll treat the male infertility factor. And as no other genetic cause, anything was discovered in this patient, we went ahead with the IUI. And after third IUI, the patient conceived with the help of gonadotropin-led stimulation. Mm-hmm. So any comments from our experts, please? Dr. Poonam ma'am or Dr. Ikika, are you there? Then I would like closing statement on this case.
Yes, actually, I was in emergency. I joined just now, so probably I'll be more.
That's fine. Next case.
So
Dr. Poonam ma'am is
Preeti, one thing I can add here. when we are foresighting less on time and more on age, we could have an assistant of a DFI. Patients with very high DFI are very unlikely to get pregnant with an IVF cycle, with the IUI program, especially with wives who are older. So here
I differ a bit
we
here
get better
because
fast track
Even I don't like.
in any case, we are
Not in
not
all
going to
cases
give
a DFI, no?
yeah.
DFI,
Because in
why?
any case, we are not going to give too many IUI cycles in this case. And secondly, because of the age factor, anyway, we have to speed up. So I think if 2 IUI cycle, and when we do the first IUI cycle anyway, when we are preparing the sperms, we do come to know how bad the sperm quality is. So usually in my practice, if the sperm quality is very, very bad, then after first cycle only, I will tell them that it's better to move to IVF if AMH values are also low. And at the most, second IUI, yeah.
Time the counts on the borderline. We all are talking from a fertility specialist point of view. But gynecologists have a different perspective. So this is just a food for thought. Sometimes the counts are like 10 to 50 million. People keep on doing IUIs even in advanced stages.
In any case, multiple IUIs are not to be done. Anyways, we know that not more than 6 ovulation induction stimulations, including IUI and IF. But your point is well taken. If AMH is miserably low and the sperm count is very bad, then might as well move to IVF faster than rather than spending time on IUI. Totally agree with this. So we close this case and then we move on to our second case, which is a little more technically advanced now. So this lady who is can you just wait? Dr. Monica is calling me on the phone. One sec. Hello? हाँ जी, wind off कर दे? Okay, but she missed that question. In the next case, I will ask her. Yeah, it's okay. Okay. That's fine. That's fine. Perfect. Let me continue with the second case. Okay. Hello, Dr. Sonu, you have joined. So your question was in the beginning, which was asked, but now in the second case, you can answer the question. All right. Now the second case is Mrs. V, age 33 years old. She had irregular menstrual cycles and she's been married for 3 years with no history of sexual dysfunction. On HSG, which was done, there were bilateral tubal blockages, and on ultrasound, on the top of it, she has bilateral PCOS. So this was her HSG finding. And my first question now goes to Dr. Monisha. Dr. Monisha Singh, how would you like to investigate this couple, please?
Again, this thing has to be evaluated back from the basic. Though we can already see that the situation tubal factor and ovarian factor is already there. So we have to jump according to the time to pregnancy. The period has to be shortened up. So we should at least jump to the IVF as soon as possible, and proper counseling has to be maintained to these particular patients. An option for laparoscopy can be given if the tubal, recanalization is there or not, but they have to be counseled properly.
Yes, Preeti, listen, if you go back to the HSG, it shows ampullary block. So why not give her that benefit or doubt of it being just a little spasm or the dye not being injected with full pressure? Because if you look at the films, they are ampullary blocks and not cornual or something.
Cornual block.
The laparoscopy is also suggestive of ampullary block.
Please, panelists, we all cannot speak. One by one only we can speak. Now, I was coming to that point only. Usually ampullary block, usually if there is a spasm, it's a cornual block. But then, yes, we can go for the laparoscopy to see whether there is an, if that it can be opened up or something. If in any case, we also need to find out the cause for the block, and tuberculosis is one of the main reasons for the fallopian tube block. So endometrial biopsy, and in this I would like to emphasize, rather than sending for plain PCR, we should definitely go for Gene Expert Plus nowadays, and also her AMH values. Next question to Dr. Bhavna.
I just wanted to add one thing. See, tuberculosis, as what you said, is even till date is more of a clinical finding than only by the lab test. Laparoscopy in this case, lapro or hysteroscopy in this case can definitely make us see is there is anything suspicious of tuberculosis so that you can take and send the tissue. Otherwise, gene expert only thinking empirically that ampullary bulk can be because of tuberculosis, I don't think so it's justifiable. If you read
Correct,
a very
ma'am.
latest
And
paper
then,
of Dr.
but ma'am, tuberculosis, even if we don't do laparoscopy, endometrial biopsy for tuberculosis in
Yes,
such cases
histoscopy
ideally
should
should be.
be,
Yeah.
should be done. If you're thinking of on the lines of tuberculosis, if everything is fine, I mean, her endometrium is fine enough, then I'm not very much sure how much justifiable is sending gene expert for her on empirical basis.
Ma'am, for tuberculosis nowadays, we send only gene expert plus.
Yeah, but for this particular case, how much justified to send this just thinking ampullary block could be because of tuberculosis? That's
For
what
the
I'm
tubal
saying.
blockage, just putting a point across for the tubal blockage, if we encounter the tubal blockage, one of the basic investigations before moving to IVF definitely should be endometrial biopsy for tuberculosis, because just in case tuberculosis is there, IVF anyway would be a failure, ma'am.
In that case, I would put up, if there is a blockage, then it is first necessary to do laparohisto before even sending EB for TB.
We can do all the three together. Yeah, that's what I was saying. Lepro, histro, and we can take the biopsy sample at the same time.
Yes,
and we
that way it is better, because ampullary blockage could not only be because of tuberculosis, it could be because of PID, it could be because of endometriosis, subtle endometriosis, which we could not see. So laparohisto followed by it as other thing.
Perfect. So, but tuberculosis has to be ruled out in India. That goes without saying before the IVF. Okay. Now, next is moving to Dr. Bhavna. I would like you to elaborate on the Poseidon criteria.
So the Poseidon criteria is basically to classify the patient as per the age, AMH, and the AFC. And based on those groups, group 1, 2, 3, 4, we could individualize the ART protocols. I mean, that's.
Would you like to emphasize on group 1, 2, 3, 4? Yeah. I've written it on the.
Ma'am, Poseidon is a criteria which goes from poor prognosis to low prognosis patients. So we divide the patient in 4 categories so that we can individualize the strategies accordingly. The aim of Poseidon criteria is help us to get increased number of oocytes so that we generate one euploid blastocyst that gives us a pregnancy rate to as close at 50% in all the age group. So with the help of a euploid blastocyst, we negate the effect of age on the success of an ART procedure. So according to Poseidon, we are divided into 4 groups. So one group, slight difference. You have placed the patient in group 1. So for group 1, the patient should also undergo one stimulation cycle. Now you have a patient who is young, whose AMH is less, whose AFC is less, and we have to take her up for ART. So isn't it she'll go in group 3 rather than group 1? Because for group 1,
she will, if her AMH value is less, she will go in group 3, and if her AMH value is more, it will go in group 1. That's perfectly fine. So what basic difference between Bologna and the Poseidon criteria was? Poseidon criteria was basically for the prognosis. It helps us in telling us the success rate, and it also helps in including the age group, and it's much more clinically relevant in planning our ART treatment so that we have maximum yield of the follicles. Very rightly.
No, but she's 33 and she's PCOS, no?
No, she is not PCOS, ma'am. This is what I wanted to say.
That
she's 33 and she's
on ultrasound bilateral PCOS, no? So
yeah,
that's why.
So,
Yeah,
this is what I
thank you,
wanted to ask.
Shanuji. So AMH value is not mentioned. So so
no, AMH is mentioned, ma'am. AMH is 1. That's what I wanted to ask.
Okay, all
your
right.
ultrasound said
it's okay. It's all right. If her age is less and her AMH is fine, then she goes in group. If AMH is fine and the age is less than 35, she is group 1. If she is less than 35 but AMH is less, she will go in group 3. If age is more than 35 and AMH is okay, she goes in group 2, and group 4 is more than 35 and low AMH. So now this lady is, we go back to the case. She's 33 years old.
Ultrasound bilateral PCOS and AMH 1. Both the things
Yes,
cannot
yeah,
happen.
very right.
Yeah, they cannot
This
happen.
patient has
No. Both the things can happen with
No,
a polycystic.
Burnt out PCOS, no?
ma'am, PCOS can never happen. PCOS is it's a syndrome, and they have a criteria for
Yes.
PCOS. That is 3.56 AMH and AFC ka. You cannot label ultrasound PCOS.
No, on
of course,
ultrasound.
No,
and
madam,
secondly,
ultrasound.
another thing is this patient we are saying
she
this
cannot
patient
have
we
both
are
the
saying
things together.
Baba,
Ma'am,
listen, Manisha, listen. She has a history of PCOS. Her present AMH is 1. We have not done the AFC count yet.
one thing is there. This patient we are thinking in terms of tuberculosis also.
Yes.
And in tuberculosis, AMH is reduced.
Yes. So it's okay. It's all right. She has a history of PCOS. Her present AMH count is 1. She has bilateral tubal blockade. So we have multiple factors in it. And that's why it's an interesting case. But I'm very happy everybody is so alert. All right. So would anybody like to expand on FOI and FORT?
FOI is follicle to oocyte index. So,
FORT is
see, this
follicle
is not...
output rate. So FORT is follicle
Sonu is
output
there.
rate.
Sorry, excuse me. Dr. Manisha, just wait. Dr. Sonu is there. She missed the first round of session questioning. Dr. Sonu, I heard you have joined.
Follicle to oocyte index.
Okay, Dr. Manisha can continue. Yeah.
So we have two terms, FORT and FOI. FORT is follicle output rate. So everything starts with pre-antral follicle. If pre-antral follicle to number of follicles which are ready on the day of OI, of the day of trigger, is less than 50%, that indicates a poor response. Similarly, FOI is follicle to oocyte index. The number of oocyte which have been retrieved to the number of pre-ovulatory antral follicle which was there. If it is less than 50%, that indicates the patient will have a poor response to stimulation.
Correct. Absolutely fine. So nowadays we are using this along with the Poseidon criteria to decide our outcome. It helps us in explaining the certain surprises which we get. Like we are thinking a young patient and she has a good AFC count, but suddenly the outcome during the IVF, the number of follicles we get, or actually the empty follicles which we get are more. So now we have a proper base to explain that, how that is happening.
And if the patient gives
Dr.
the previous history of this, if patient gives a previous history of this kind of picture, then we can plan our treatment in this cycle. We can add LH or LH or HMG in this.
Absolutely correct. Dr. Niharika, are you there? Somebody who has not answered any questions, can you take this question? Role of insulin sensitizers in PCOS? Okay, I think we'll just skip PCOS because her AMH is 1. So then Dr. Manisha, now what stimulation protocol in this case you will follow?
So ma'am, for me, as I follow antagonist protocols for all my patients, and also more in cases of low ovarian reserve. But for people with low ovarian reserve, I would like to do little pre-planning pre-treatment before I go for my IVF. For these are the patients, if we need to have more synchronized growth, and for that we probably we give E2 priming in our previous cycle. We give antioxidants in our previous cycles, and I give androgens in my previous cycle. And while deciding the dose of my antagonist cycle, now if you look at Poseidon, it says that you have to start with 300 of rec FSH. So what I normally do is I add little LH to my protocol so that it increases the synchronization and growth during the cycle. And for trigger, I usually prefer a dual trigger in these patients.
So in what form you add LH?
So ma'am, I normally add in the form of HMG LH because recombinant LH is very expensive.
Correct. This was what I wanted. I wanted the same answer, that we don't have to spend so much of money in recombinant LH. We can just add a little bit of HMG and it will do the purpose.
In the latest ASHRAE guidelines, a lot of talk was on androgens, and a big randomized study was done, and it was revealed that testosterone, this androgel, is not giving really good results.
Madam, the latest guidelines for Poseidon, if you check, They are saying androgens in the
They would
form
add
of
adjuvants, huh?
testosterone gel.
No,
They do have a role, not in the
see,
form
that
of
was the old thing. The
testosterone.
recent,
No, madam, I'm talking about the latest one.
No,
If you look at the
2020, I'm talking about 2023 guidelines, 2023 ASHRAE. There are a lot
Yeah,
of
it's okay. It's all right.
discussion was done on
Dr.
this.
Sapna is right about it that the latest guidelines, they say that the role is debatable, but then again it depends on one's own practice. I always feel that as in India, the number of patients which we are dealing with is much higher than the European cohort. So it's high time we should not just blindly follow the guidelines. We should go back to our own cases and see what is the results. I have been using androgens quite a lot in low AMH patients. Okay, the results are debatable. I mean, at this point also, I'm not very sure whether testosterone gel is helping at all. So, but then we do use it thinking that even if we get one follicle extra or the quality is bit extra, we'll be happy. But then again, we all need to pull up our data and publish our own results, or at least we should revisit our own patients and keep on changing it, because in IVF, everything is in gray zone. Nobody knows what works. So it's everyone's own protocols and what works the best. That I think Dr. Sapna will agree with me that as your experience grows, you know that a few things work, few things do not work. Even if they are mentioned in guidelines, we don't blindly have to stick to the guidelines. Anyway, but we need
This is one more thing, Preeti. Know what? I use a lot of Rec LH. So what I do for the cost cutting that I do is I start with Rec FSH and Rec LH, and then I always see an even cohort coming up, and then I change to the entire HMG.
Correct,
So I have
correct.
more M2s and more day 5 embryos. That's my
Yeah.
experience. So I am swear by Rec LH 75 IU in every
I
most
use
of my
Rec LH, but I found the similar effects with HMG. So, and anyways, it's fine.
everybody.
With the growth hormone, I use a lot of growth hormone, and I found very good results with it.
Yeah,
And
yeah,
one
yes.
more thing which
Any
I do is
any added benefit of HCG? Some they say some HMGs they contain HCG containing HMG.
Ma'am, I did not find it. I used it, but I never found any extra benefit. But one thing which I definitely do is I always counsel them for the ovarian PRP during the time of pickup. And I do lots of ovarian PRP and I'm getting beautiful results with it. I've done almost 30, 40, I would say around 40 cases of during the pickup, I do the ovarian PRP and in embryo pooling. And in the next cycle, it really helps. I mean, I'm too happy with that. Anyways, we move on. So, Dr. Sapna, are you there?
Yeah, I'm there.
Dr. Sonu, are you there? I got a message that Dr. Sonu is here. Anyways, one sec, let me just check. Dr. Monica, are you there?
Yes, ma'am.
So, Dr. Monica, I'm not getting Dr. Sonu anywhere. Like you.
Ma'am, I just spoke to her. She has an emergency, so she's left the meeting.
Okay, that's fine. It's fine. So I just wanted to involve her in the panel. That's why I asked. So Dr. Sapna is also not there.
So I'm here. I'm very much here.
Dr. Sapna is here. Oh yes, you're right in front of me. So please take this question. Your tips and I want your own personal tips and tricks for the oocyte retrieval. No guidelines. Your trick. Your personal way.
The most important tip for tips and tricks, the most important thing is you have to check your equipment, because equipment failure should not happen on that day, and you should have something standby, because if suction fails, I think for me suction is a very important part of the equipment. One extra should be there. And
yes,
another thing is the type of needle that you are selecting, because it is very important to understand that the maximum pressure is not at the tip of the needle, but it is more distal to it. So how you are doing the oocyte retrieval is very important. That once you enter, when you enter the follicle, and you should not have too many entries, just with one entry in one ovary, you should be able to take out all the follicles. You should try to do that, and you should press the foot pedal only once you enter the follicle, not before, just before entering, because that pressure, when there is a steady pressure, you are able to get the oocyte properly. And once you take it out, just after that, because maybe if there's some oocyte is there, it will go back if you remove the pressure, before that. And of course, the temperature has to be maintained properly. The collecting bottles, you should have a proper temperature, because 1 hour before that they should be the temperature should be maintained, and because the oxygen, dissolved oxygen level, the carbon dioxide pH and all that gets changed, and the oocyte quality definitely gets affected, and of course temperature and all those things.
Yes, very rightly said. So now some tips by all my panelists one by one about the factors enhancing success during embryo transfer. So Dr. Shanujit, what kind of catheter you would like to use?
Okay, so we use a soft catheter. So we're using Cook's catheter for transfer, and the tips and tricks again. Let it not touch the fundus. Let the tip of the catheter stop short of fundus, maybe about 1 centimeter, so that that's when you push. And then I make a point to clear the mucus if it is there, just with the tip at the external os, no suctioning with the syringe, just cleaning the mucus at the tip if required. And then as it is, we don't make the patient lie down. We make them get up as soon as possible, because it seems now that including going and passing urine also increases the vascularity, it seems. So that has worked. So no resting, and as gentle as possible, not touching the fundus, under ultrasound guidance, that's all. And I always do a mock embryo transfer, so that I don't want to be caught unawares on the day of the ET.
Perfect. Dr. Sapna, what's your take on it?
I give lot of importance to mock transfer, because sometimes sometimes the cervix it is crooked, and in those cases I use a Cook's catheter. Otherwise I'm using the soft Vallus catheter.
All right. And any other trick you would like to tell at this point of time, Dr. Sapna? Anything else you take care of?
I think the best part with mock transfer, which Dr. Shanujit has already told, no?
Yeah.
Transabdominal guided, we have to do a mock transfer. That's most important, because I think 30 to 40% of patients, we feel there's a difficult transfer thing can be there. So we I do use sometimes with the obturator kind of Vallus catheter sometimes, because I do feel, I mean, last 2-3 months I've felt 2-3 patients it was a difficult transfer. And secondly, some assistant should be a trained assistant, so that they can show you the proper trajectory of the endometrium. That's, I think, again a very important part for embryo transfer. And temperature maintenance from the lab to the OT is again the way thing. When you pass on your embryos from the lab to the OT, the temperature difference should not be there.
Right. Dr. Manisha, any inputs?
Within 120 minutes. And if any retransfer is done, at times the embryos are left and you do it, it has to be done fast. And everything sterility should be maintained, and we should be prepared for hard catheters also. If we encounter difficulties, we have those catheters available with us, because we have some patients like the cavity is really bad. It is like an S-shaped cavity. For that, even if we have done hysteroscopy, you are still more aware and more, you have hard catheter available, you can easily negotiate, and you don't have any problem on that day.
We can have this transfer under GA, short GA also, when you can give Buscopan.
Yes.
So.
Yeah. I do a few transfers in short GA, because some patients are not comfortable. They have severe dyspareunia or something. So, and then we do it, and good results are there. Any take on abdominal versus vaginal ultrasound during the transfer?
Ma'am, we have there was a paper where they say ki TVS is also good enough, but now we have realized that if you have a good assistant, TS is an excellent method. We don't put anything inside during a transfer. I believe even if you touch your cervix again and again while cleaning also, that can also stimulate contractions. So by putting the probe, we are already increasing it. So it's better we avoid all these things. And TS gives very good results. We are now, I think, very much, we can easily do our transfer with TS. So I don't think vaginal gives any other advantage over TS.
Perfect. So now we will just wind off with 5 slides about the latest advancements in ART. So we start one by one. Dr. Manisha, any 2 lines on epigenetics?
Let's not forget that epigenetics does exist, and especially in India, where we are living with so many, infectious and the conditions like methylations and all these things from smoking and everything. So let's not forget, I think off the topic when we were discussing about the IVF, the situational and difficulties and how can we like the desi jugaad with us, I would definitely say, let's not forget the nutraceuticals that are also there. There is a huge role, even though there is an indefinite in order. Also, the cold chain maintenance of each and every drugs that has been transported, the quality of the drugs and hormones that has been given to the patient matters a lot. So a good company should be there.
Yes. So Dr. Bhavna, anything on the Garbh Sanskar? Do you believe it? You don't believe it? Anything? Is she there at all? I think she has left. That's okay. So a lot of work is being done on Garbh Sanskar. And
Garbh Sanskar, yeah, I just want to add up because I'm from Haridwar and Garbh Sanskar is there in too much in the Shanti Kunj area, if you guys must have heard of. And background में अगर आपको music सुन रहा हो तो सब कांवड़ियों का बहुत सारा music चल रहा है इस समय. So it might be a disturbance. I know. So this thing, Garbh Sanskar gives you a kind of spiritual behavior of you when talking to the patient and having all things. I think I really feel it gives you a little meditation kind of thing. It should be given to a lady.
It's
So
good.
we do advise.
It's good. And it's good. Yes, absolutely.
I don't know whether it's good or not. It's all your own perception, I think. But now at this age, by this time, we feel it should be done actually. There's no harm in doing all these things. So spirituality and a little bit, I do tell the patients to go for a little bhajan daily in the morning, or maybe prayer. This thing is very, very important. Keep talking to your kid also, baby.
Absolutely. Absolutely.
So
when we are playing
may not work, but gives you confidence actually.
Rate of 35%, then anything which will help is always, in fact, meditation will help the obstetrician and the infertility expert also, because negative results are so disappointing and so stressful.
Yeah, very much. Yeah, that's.
So Dr. Niharika,
I'm sorry. I need to just sign up. Sign up this. That's
fine.
Let me.
Thank you so much for joining. Lovely to have you.
Thank you.
So, Dr. Manisha, just one word on, are you doing PGS at all?
Yes, ma'am. I do a lot of PGTA. So now it is pre-implantation genetic testing for aneuploidies. I do a lot of PGTA because I have girls which start their cycles and 40, 42, 45, 47. So now there's a girl for which I'm doing PGS at PGT at 47. So if I have to implant the embryos, I have to check and do. Then I do a lot of patients with recurrent implantation failures, 5 failures, IV 6 failures. So they want to do their own embryos. So for them, I think it's a good opportunity, and especially if you're going for reset.
Yeah, of course, I love PGTA and PGTM, and I've been doing it for a long time. And I really feel it is something, if possible, should be done. But of course, the cost limiting factor is there. Anyways, now a lot of you and cry about non-invasive PGS, but we all know that it is not 100% sensitive and still a long way to go for the non-invasive PGS, and I'm waiting for it to come.
Now they are saying that
NICS, we are doing NICS also, that is non-invasive PGS.
Yeah,
but the only problem with NICS is you have a lot of low mosaics in NICS, and secondly, at times the DNA extraction is not there. So that is the problem.
That's what I said. That's what I said. A long way to go. It's still experimental.
And the companies are suggesting that while you're doing a PGTA, you simultaneously do a non-invasive so that we can compare the two in the long run. We have data, So we have data, and then we can
data building.
Actually, the denudation part of the cumulus has to be done properly. They should not.
Correct. But at this moment, we cannot replace PGTA and
PGTA with non-invasive.
So ERA, again, I do lots of ERA. I like it. But
I also do a lot of ERA, ma'am, because I get a lot of failure patients.
Yes,
I'm done with ERA, and I do a lot of duo-stim now. So for all my and the LPS somehow turns out better than FPS. I don't know, maybe we are better prepared, and we learn from the FPS, and the LPS turns up into better day 5 embryo. So I do a lot of duo-stim.
So I will like to now, sorry, Manisha, I'd like to interrupt because all of us need to go long day. And before going, I would like to invite all of you to Cause Gynae 23. I'm sure you all must have heard about it. On 29th, 30th July, we are doing this mega event in Chandigarh. It is an annual conference of INSARC, and it is not only about cosmetic gynae. There are 4 halls, A, B, C, D. A hall is all cosmetic gynae, B hall is all infertility IVF, C hall is mixed batch, and D is poster presentations and other lots of things. 150 faculty is coming. So I look forward to inviting all of you there. And if anybody of you would like to be a speaker, please come in touch with me, because we have on popular demand raised the hall D. So I still have 3 spaces in the hall D. All sessions are back to back. There are more than around 200 lectures are there, and lots of faculty, national and international, are coming. So really looking forward to seeing all of you. And it was a lovely panel. And thank you so much. And Solapur people, I am really thankful to you. And many of you are coming in Cos Gynae in 23. And thank you so much for having us here. Good night. And
Thank you so much. Thank you so much, Dr. Monica and the organizers. Yeah.
Thank you, ma'am. Thank you for having us here.
Yeah. Okay.
Thank you, Preeti ma'am, for the excellent panel. Thank you all the panelists for your feedbacks. I am sure the delegates will have a lot of take-home messages.
Yeah.
Bye-bye.
Let me officially propose the vote of thanks. I would like to thank Mr. Sharma ma'am, Rishikesh Pai sir, Dr. Sarveshwari Notial madam and Sujata Sharma madam for accepting our invitation and blessing this webinar. I thank the speakers, Sadhana Gupta madam and Kanchan Sharma ma'am, our moderators, Dr. Rajul Tyagi madam and Dr. Preeti Jindal ma'am, our experts, Poonam Lumba madam and Ekika Singh ma'am, for accepting our invitation and being there. I thank Corona Remedies for their technical support and all the panelists who have joined.